Then once the session starts, you can go back, switch off your laptop, and come back and for your session. It will restart the webcam.
Indrajit, what is happening about Ajoy?
Sir, he is not answering phone, not replying to messages. I'm trying.
To me?
Ajoy.
Oh, Joy. I thought you said me. I'm like, I'm right here.
You're right here. Yeah.
Indrajit, I spoke to Ajoy and Ajoy is getting live soon.
Okay, sir. Thank you.
Indrajit, can you help me? I don't know why.
So you will have to restart your laptop once.
Okay,
You'll have to shut it down properly and restart
I'll
it.
do it. I think, is it okay now, Indrajit?
Yeah.
Okay, Vora.
Hi, morning. There was some problem. I don't know what I was going through, but
Yes, Surya, so you're clear. Everybody has joined. Rajiv sir, I think we can start.
It's 9 o'clock.
Dr. Raja, can we start, please?
Yeah, we can start live.
Yes, we are live, sir. Please go on.
Okay. So, good morning, everyone. I welcome everyone for the Ifas Corona Curtain Raiser program. And on behalf of Ifas and the Parekh Family Foundation for organizing this program. It is a curtain raiser for our IFASCon Kochi, and today is an important day that we are going to see about both Indian and global perspective of calcaneal fractures, approach and algorithm to flat foot reconstruction, and indications and technique of total talus replacement. I thank every one of you for joining this program, the moderators, the presenters, as well as the ortho group who's all joining from different locations. I welcome everyone and we start our program today. Thank you very much.
Thank you, Dr. Raja, and good morning and welcome to more than 13,000 orthopedic surgeons who are joining us, who joined us all across the country. IFASCON, as you all know, is the prime event of Indian Foot Ankle Society, and we thought that for this particular event, let's raise an echo. Thank you very much to the Parekh Family Foundation and Dr. Celine Parekh, who has been mentor to most of us, who readily agreed, and the foreign faculties who readily agreed to join at the very odd hours during their family time, during the time when they are to sleep. Well, we have galaxy of foreign faculties as well as we have very, very talented Indian faculty and expert moderators, and I'm keenly looking forward to this event. Before I ask Indrajit to go ahead and give some housekeeping instructions, let me again welcome you all. Let me again thank all of you and keenly looking forward to this event. Over to you, Indrajit.
Good morning, everyone. Welcome to the program today. This is a curtain raiser to IFASCon, our annual conference that will be held in Kochi. If you guys have not registered yet, please go ahead and do so. We will shortly start the program. There will be 3 sessions of 1 hour each. Every session will be moderated by one faculty who will be taking questions on the platform with you right there. You can put your questions on YouTube. You can put your questions on the platform you are visiting. Once the questions are received, we'll take the questions at the end of every session. Thank you so much. And can the first moderator start the first session, please?
Yes, thank you so much, Indrajit Singh, Raju Shah sir, and Celine Parikh sir for this platform to learn. Can I share my screen? Yeah. So, We are going to discuss first on approach to calcaneal fractures. And we have got international as well as national perspective on this. Our first speaker who is going to give us international
So you can
perspective
share your
is,
screen.
yes, I did
You can
that.
share your screen, sir.
Yes. Are you able to see now?
No.
That's fine. Indrajit sir, we will not waste our time because I want
Sure,
it
sir.
to start on time. We have got Dr. Rishin Kadakia from Emory University School of Medicine. He's assistant professor over there. We are fortunate to have him here to talk on the international perspective on fracture calcaneus. And we have got Dr. Kashyap Ardasena, who is from Gujarat, and he is having a lot of work on MIS calcaneus. We have requested him to show the technique from Indian perspective. We know calcaneus fracture is one of the commonest tarsal bone fracture, and pendulum keeps on swinging from conservative to surgical treatment. And in surgery, we have got classical lateral extensile approach to MIS. So we will like to listen from our experts the technique and approach to the calcaneus fracture. Over to Dr. Rishin for your perspective. Thank you.
Thank you, guys. Let me share my screen here. Okay, can everyone see this?
Please go ahead.
Yes, sir. Perfect, sir.
Okay, perfect. Again, I want to thank Ifas for having me to give this talk, Dr. Parekh for getting me on for this. This really is an amazing event that you guys have organized to coordinate so many centers at one time is quite fascinating and interesting, and I'm excited to kind of hear the discussions and perspectives, both from all the different faculty who are on across the country over there. So let's see if I can look to move forward. Perfect. So these are some of my relevant disclosures. I do a little consulting work. A little bit about me. So I'm a orthopedic foot and ankle faculty at Emory in Atlanta, Georgia. Did my med school training at Vanderbilt in Nashville, Tennessee, a state kind of north of Georgia. Then I did my orthopedic residency at Atlanta and Georgia, and then I did a foot and ankle fellowship at Duke. And I actually trained with Dr. Parekh. Learned a lot from him, as it sounds like everybody on this call has. So I run our orthopedic foot and ankle fellowship. I'm a program director for the residency, and I grew up in the States, was born here, but my family's actually from Bombay, but for my wife's family as well. So. My family's in Tardeo, and most of her family's in Bandra. So, we visit India often, and it would be awesome to get involved with this organization, on a more in-person level as well. So, before I go too far, for most of you on this call, I'm sure this was a phenomenal day and night. I just had a child, and my father-in-law has been staying with us, and I really got into cricket over the past month. I thought it was phenomenal, the skill required to have this catch. And I don't think I could give this talk without showing this at least one time. So, I want to say congratulations to all of you. The drought that has finally ended, and I'm surprised so many people made it to this call this early, because I'm sure most of you were out quite late last night. So hopefully everyone really got to enjoy this. So, I'll start with the case. This is a 17-year-old female coming in with heel pain. She was, enjoying her summer, jumped into the shallow end of a pool. Otherwise healthy female, non-smoker. Her exam's pretty benign. It's closed. A lot of bruising, swelling, otherwise neurovascularly intact. So these are her x-rays, demonstrating a highly comminuted intra-articular calcaneus fracture. She's got calcaneal height loss. When you look at the axial view here, not a lot of varus valgus, but you can really see that her joint is quite compressed and crushed here. So this walks into your clinic. Initially you see something like this. Most of us that treat these injuries, that see these patients both at the start and long term, know that these are quite devastating problems, especially for a 17-year-old. So, initially this is quite a shock, but once you get past this, what do you do? When do you choose to operate? When do you treat this conservatively? If you decide to have surgery, what approach? Do you try something MIS, open, and kind of what happens long term? So as we go through the discussion today, we'll kind of go through the decision tree of how we go about deciding, where to go with calcaneus fractures. So, a little bit, why are these injuries so bad? A lot of this comes down to the mechanism. These are high energy injuries. A little historical reference, these used to be called, were also called lovers fractures or Don Juan fractures. As you can imagine, somebody escaping a place they're not supposed to be in the middle of the night and jumping off a balcony and breaking their heel. So I'm sure this happens still now, but we commonly see these in car accidents. These are quite high energy injuries. So there's a lot of crush injury to the bones, the soft tissues. There's vascular compromise. A lot of these patients get neuropathic problems because of the neuropraxias that develop or the injuries to the small nerves in the foot and the ankle. And the main issue here is the articular injury that occurs at the time of the injury itself, and that sometimes is just irreversible. So, that quote at the beginning that I showed, the man who breaks his heel is done, is from a JBJS article back in the early 1900s. And even at that time, they'd kind of determined that these are quite devastating injuries from a functional perspective. Even if these heal well, you do everything right, these patients can still have problems. So, again, what makes these challenging? I think the biggest thing is the injury mechanism. This is a high energy axial load on the foot, and this leads to severe soft tissue compromise, articular damage, and these patients often have concomitant injuries too, as we all know, particularly in the spine as well. So, there's a lot of literature that has looked at the kind of long-term outcomes after calcaneus fractures. This is a study published in JBJS up top out of Duke, where I trained, and they looked at 12 years out, and these patients, even after they were fixed, they had a good outcome surgically, their AOFAS scores are still relatively low. It just goes to show the functional consequences of this injury, even when appropriately managed. And again, the study below showed that only 50% can return to work. So again, regardless of how you treat these, and even when you treat these appropriately, these patients have long-term problems. And a lot of times this is an injury. When I see a patient, I spend a lot of time initially explaining to them that, hey, listen, this is going to be a long ride. So getting to the kind of meat of this, the decision tree here. So, calcaneus fractures, as was stated earlier, have kind of gone back and forth. Do you operate on these? Do you not operate on these? And there's a lot of literature to support both. These are two studies, just two sample studies that have looked at operative versus non-operative outcomes. The top is a meta-analysis of a bunch of randomized controlled trials. The below is a randomized controlled trial from 22 hospitals in the UK. And kind of both of these found that there was really no difference in outcomes functionally, but there were higher complications with surgery. So this is an injury where, we have an inclination to always want to fix the fracture or fix the problem, but sometimes operating on these can lead to more problems, and especially if there's not really going to be a lot of functional gain. So there is definitely a role for conservative treatment for calcaneus fractures in my mind, and we'll kind of go through which fracture patterns I feel are best treated with surgery. So these are some of my indications to operate on calcaneus fractures. Again, this is very subjective. I'd love to hear the discussion of the faculty on later. But again, any patients that has any kind of vascular path or any kind of vascular issues, a smoker, uncontrolled diabetic, I'm not operating on their calcaneus. The soft tissue risk or the risk of infection, wound healing issues is simply too high. They have to have an adequate soft tissue envelope. In my mind, that's the most important part of this surgery is getting the soft tissues to heal. You can do a fantastic job fixing these fractures, but if your incision doesn't heal or you get any kind of wound breakdown, it doesn't really matter. So, again, if the two criteria above are satisfied, then the next questions that I ask are, can I make something better? Can you make the articular surface better? Can you restore the height? Can you restore the coronal plane, so varus valgus? The surgery has to serve a purpose. If the articular surface is shot, that you can't restore the height, you can't correct deformity, then there's not a reason to operate. And again, obviously, open fractures, tongue types where there's soft tissue concern, these need to be fixed. And again, with this surgery, you're always considering the next surgery or the fusion procedure that a lot of these patients ultimately need, or sometimes they don't have a choice. And that's where restoring the anatomy in terms of the height, getting these patients out of varus is crucial because, as most of us know, dealing with a calcaneus fracture malunion with subtalar arthritis is quite an undertaking. So let's say, you decide that, all right, I've got a calcaneus fracture, I got to fix the two kind of routes or the two boxes I look at next are open versus MIS. So now when I mean MIS here, what I'm kind of referring to is not a true surgical approach. So not visualizing the subtalar joint. So, a sinus tarsi approach or an extensile lateral, I would put into the open bucket. But MIS or things like percutaneous techniques or percutaneous reduction maneuvers to then stabilize the fracture, and then you use percutaneous fixation or placing the patient in some type of external fixator, which I actually do quite a bit of. So looking at the MIS and XFix criteria for me, again, soft tissues for me with this injury. If I have any kind of soft tissues that are in the gray zone, I'm worried, is this incision not going to heal? Can they tolerate an incision? Then I'm going to kind of think XFix or something more MIS. If I have a fracture where the articular surface is well maintained, the posterior facet looks good, but really they're just in varus or their height's lost. Well, that's a good case for MIS or even an XFix. So, I think with any MIS case, these injuries have to be acute. You can't have callus, you can't have scar tissue that is formed. Otherwise, the fracture fragments just won't move. XFix, so I work in one of our level 1 trauma centers, and we'll see a lot of these that we just have to XFix because they're open injuries, they're severely comminuted, there's severe loss of height that you just can't fix. And with this, I prefer a medially based XFix. So again, this is just a case series that shows the technique that I like. This medial XFix, you pin in the distal tibia, a cuneiform pin, and then a medially based calcaneal pin. The idea here is with the medial XFix, you can really maintain your height. You can jack this XFix to get the height you want, but also keep this fracture out of varus, which to me is one of the biggest problems with calcaneus malunions is the varus that can result that if they're not treated appropriately. So thinking about MIS techniques, again, what I'm thinking about here are percutaneous or closed reduction maneuvers, and then a variety of techniques to percutaneously stabilize this fracture. So this is actually a study out of Asia published not too long ago where, they use large Steinmann pins, as you can see, placed here in the back of the heel to maneuver the fracture fragments, then create a plane posterior laterally between the perineals and the calcaneal bone itself. So you kind of create this dissection posterior laterally and slide the plate. I've tried this technique a couple of times. I've found it difficult to really get the plate over to dissect, subperiosteally to get the plate where you want it to be. But the results in this study have demonstrated that this can be done pretty well. This is a technique actually out of Europe where they use these 2-point distractors that I've kind of shown here at the right. I haven't necessarily tried this, but I thought this was interesting to show. They'd put in 2 pins, one in the talus, one in the transfixing pin in the calcaneus, and then put these distractors both medially and laterally and kind of use these as levers, again, to maneuver the fracture and then percutaneously place screws, across the subtalar joint or to kind of raft the subtalar joint. And again, they perform these acutely because, you're not really making an incision. and there's a low complication rate. So now when I think open, again, I'm looking mainly at sinus tarsi and extensile lateral. And again, you have to meet all the surgical indications. The soft tissues have to be amenable to an incision. For me, any kind of articular incongruity or any kind of displacement at the articular surface that we got to restore, I got to be able to see it. That's, again, just a personal subjective thing, but I prefer to be able to see the joint and reduce it well and visualize it. So, and again, more chronic injuries just don't do well with MIS. They're just difficult to mobilize. These fracture fragments just don't move. So going back to our decision tree, the two big approaches that I utilize in practice are the extensile lateral and sinus tarsi. I'm excited to hear about the sinus tarsi approach from our colleague in India. I do a lot of extensile lateral, but I do like sinus tarsi for certain approaches, for certain fracture patterns, and I would love to hear if anyone has experience on the call with the medial approach or any other open approaches. So again, sinus tarsi, starting at the tip of the fibula, going to the base of the fourth metatarsal, shown here on the left, the extensile lateral on the right. There's some variation as to the longitudinal arm. I like something kind of more halfway between the back of the fibula and the lateral border of the Achilles, and then in line transversely with the base of the fifth metatarsal. These are my favorite cases to show at our indications conferences at our institution, just because, everyone is very polarized. Some say that, oh, you can fix any calcaneus with the sinus tarsi. Some need an extensile lateral. So these are fun to kind of incite discussion because everyone really has their own opinion and there's truly not a right or wrong. When you look at the literature, there's tons of articles out there comparing sinus tarsi and extensile lateral. And, these are just three examples. And, when you look at these, the summary statement is always less wound complications, less operative time with sinus tarsi approach. But, in my mind, can you really compare these two approaches? Because they're two very different approaches that should be utilized for very different purposes with regards to calcaneus fractures, which come in a wide variety. So in reality, I don't think one is better than the other. I think it's more about using them in the appropriate indication based on the fracture pattern. So again, for me, or at least my thought process with this is, I use a sinus approach except for the following. So if there's significant displacement medially, particularly at the medial facet or the medial aspect of the posterior facet, I find this hard to truly visualize through a sinus approach, especially if there's a lot of lateral wall displacement or lateral comminution that needs to be moved to adequately restore the medial aspect and restore the anatomy at the constant fragment. The other times that I found a sinus approach to be difficult are chronic injuries. These patients swell, and sometimes you have to wait weeks before you can truly get to their fracture. And, in those cases, the fracture fragments sometimes just aren't mobile. The lateral pieces you can get to through a sinus, but medially, if there's displacement that's scarred in, I find that difficult to get through a sinus alone. So again, the approach you utilize has to allow you to accomplish the goal that you set out with, which is to restore the alignment, to do what you can with the articular surface and maintain height, which ultimately gives this patient the best long-term outcome, even if they need a subsequent subtalar fusion. So, again, a lot of debate, and this will be exciting to hear everyone's thoughts on fixation constructs. Do you use a plate? Do you use rafting screws, large cannulated screws alone? Do you do both? Again, tons of literature on this. Anytime I see tons of literature on a specific topic, it usually tells me that there's not a right or wrong to it. And it really comes down to experience, comfort level, and what you feel good about. The consensus is that plate fixation gives you more reliable reduction and maintains your reduction long term. This is a good study actually published this year that showed that plates hold your reduction better than screws alone. But there is a higher operative time to putting these plates, particularly through a sinus approach. It's tough. You have to you have to create your subperiosteal plane to put the plate. There's wound risks. So it's a technical challenge, but provides a little more stability from a construct perspective. So, for me, it really depends on the fracture pattern. If I'm doing an extensile lateral, I use a larger calcaneal plate that really spans the entire calcaneus, kind of like the bottom left here. If I'm doing a sinus, I prefer to use a sinus or a more sinus focused or a kind of a wave plate, as we call it, kind of here on the bottom right. Just because I prefer to put a plate if I can. The only times I've really truly used screws only is in younger patients who have really healthy bone and really large fracture fragments. When you see that large lateral aspect of the posterior facet that's flipped and really there's not a lot of joint comminution, good bone, then yeah, I feel you can fix it with screws alone. But for me, more commonly, I'm finding the comfort level is better with plates. So let's kind of get back to this case. I'll show a little bit of the surgical technique that I like to use for these kind of injuries. Unfortunately, I don't have a video of her case, but I've got some good fluoro shots that hopefully can be of value to you guys. So again, 17-year-old girl at a pool party, jumps into a shallow end of the pool, smashes her heel. Again, you can see the level of articular damage and joint compression and height loss she has here. A kicker I didn't tell you before was that she's about 3 weeks out. She was turfed around to a few pediatric hospitals. The ortho peds guys didn't feel comfortable taking care of her. She's kind of more of an adult, although she's not 18. So ultimately ends up in my clinic 3 weeks out. So, this piece kind of scares me a little bit when I look at this kind of axial view. There's something going on there at the medial aspect. Her medial wall, just that there's a piece flipped that I'm kind of already thinking, how am I going to get to this laterally alone, through a sinus? So, when we look at her CT scan here, you can really kind of see this flipped piece I'm talking about. If you look as I scroll through these cuts, there's a large part of her facet that's actually flipped and rotated 90 degrees. So, as I'm scrolling through this, I'm thinking, all right, this is a healthy 17-year-old female, a lot of articular displacement, some of which we can't fix, but, there's significant height loss. So, bad injury, but, we can make this better with surgery to give her a good long-term outcome, or at least better than treating it without. So definitely surgery for her. She's 3 weeks out with the level of displacement, not really a candidate for MIS or XFix. Now, if she had presented to us acutely, would I have considered XFixing her? I probably would have. I would have thought about XFixing her, restoring her height, keeping her in the XFix for a couple of weeks till her soft tissue is resolved, and then consider surgery then. And then again, here, sinus extensile, I would love to hear from our sinus tarsi expert overseas as to whether this can be managed with the sinus tarsi approach. Just because I think with the level of displacement medially, this is one where I, would think an extensile lateral is best. But again, would love to hear the thoughts on that. So, we went with an open reduction internal fixation with an extensile lateral approach. The key here, as I've kind of stressed in an annoying fashion, is the soft tissues. This approach is notorious for wound healing problems, particularly at the apex or tip of this flap. The lateral calcaneal artery provides most of the blood supply to this area. And that apex or that tip of that flap is a watershed area. So you have to be very careful retracting this. I don't use any retractors here on the skin. Minimal retraction from like SINs or Army Navies. Thick flaps, full thickness flaps down to bone with the skin, with the initial incision, and immediately elevating this flap over, taking everything with it. And as soon as I get to a place where I feel I can feel start to feel the talus, the anterior aspect of the calcaneus, and even the fibula, I go ahead and put in these large 2-0 Steinman pins you can see here. I put one in the fibula, one kind of in the talar dome, and one in the talar neck, and I bend these up. And I use these as my retractors so I don't have to touch the flap. I have an assistant who's every couple of minutes putting some saline on this flap to keep it moist. And again, flap protection is key with this. So for me, this allows you direct visualization of the entire lateral aspect of the calcaneus. Again, this image here on the left is after we've exposed everything. We've put some K-wires in to kind of provisionally reduce the posterior facet. And you can see the level of bone loss here with this injury. I mean, it's quite remarkable. When you fix a lot of these, you start to see how much, the impact of crushing the bone really does, particularly when you get their anatomy restored. So again, these are more fluoro shots. Again, here showing axially, we were able to, take the lateral wall. I completely take it off, put it on the back table, remove any of the lateral facet, put it on the back table in a wet saline gauze, keep it nice and moist on the back table, and then work medially, build the medial aspect of the calcaneus, particularly the articular surface, and work laterally. So that's what we're doing here on the left. You can see that we've kind of restored the medial aspect of the calcaneus. And again, more images here showing top right, more of the articular surface restored. These are lag screws that I place once I get the posterior facet reduced and restored. And I usually like to fill my void with cancellous chips. I'd be interested to hear what everyone else is using, whether you take bone graft or not. But in a healthy 17-year-old, I filled this defect with cancellous chips. And again, using a large calcaneal plate to kind of hold everything in good alignment. So, her axial alignment looks good. We're able to restore her height. So in my mind, we've kind of taken a very bad problem and done the best we could with it. So, of course, like I said, the wound is the biggest problem with these. And, she's 4 weeks out, super healthy 17-year-old girl, still had a little skin edge necrosis at the flap. I kept these Allgauer Donati sutures in for close to 5 to 6 weeks. A little wound care, local, some PO antibiotics. Ultimately, this healed, but you can see even in a healthy patient, you take all the precautions you can, and sometimes this is still a problem you see. So that's why surgical indications are crucial for these injuries. She's 1 year post-op. She's a couple of years out now, but I haven't seen her back. I think she moved or went to college or something. But at the time she was a year back to all her activities. But again, she's only 18. What's going to happen 5 years from now or 10 years from now, right? A lot of us see these patients in their 40s, 50s with terrible subtalar arthritis, and who knows what's going to happen to her. But, I think the key here is her alignment is maintained, her height is reduced. So if she does get subtalar arthritis, which she will, but if she gets symptomatic enough warranting an arthrodesis, we've made that procedure much more simple and likely to have a good outcome. So, thinking about calcaneus fractures, these are terrible injuries. They can have devastating consequences functionally to the patient. This is an injury where sometimes not operating is the best route. Complications can occur. You can get wound healing issues. And when patients get wounds with these problems, with these surgeries, they are not easy to heal, and you can go down a bad road sometimes that can end in an amputation. So you got to be importantly cautious when choosing which patients to fix. MIS sinus approaches are great. I'm excited to hear the next talk on the sinus approach. But you got to be careful of the drawbacks or the things you can't do with these procedures. And again, you got to remember the goals of maintaining height, alignment, and restoring the articular surface the best you can. And counseling patients, these are patients you spend a little bit of extra time with, really explaining to them that this is a bad injury. And even with the perfect surgery, there are still probably going to be some functional consequences. So again, I want to thank, you guys for having me do this. It really is an honor to speak to all of you, and I'm excited to hear everyone's perspective, and I'll take any questions at this time.
Dr. Rishin, thank you so much. We will take the questions at the end of this session after we hear to Dr. Kashyap also. And thank you for great analysis about the factors, how to choose MIS versus open. Thank you so much. Now I request Dr. Kashyap to talk on Indian perspective of how we manage on the fracture calcaneus. Over to you, Dr. Kashyap, sir.
Is my screen visible?
Yes, sir.
Okay, my sound audible?
Yes, sir. Absolutely. Please go ahead, sir.
Thank you, moderator sir, Sampath sir. Thank you, organizer of this event, Raja sir, Rajiv Shah sir, and Selen sir. Thank you, Corona, for giving me opportunity to present my work. So my job of building a platform is made very easy by Rishi, because he has almost given all overview about the calcaneus from the history to the current perspective and the future perspective too. So I'll be directly jumping onto the technical aspect of calcaneus displaced interarticular fracture by a sinus tarsi approach. My presentation is divided into two parts. In the first part, I'll give a step-by-step technique in a case. And second part, I'll do a video real life surgery kind of a thing. So both the cases which are chosen are a kind of an elementary type of case, which are good to start by the people who are new into this. So minimally invasive, I got a new definition from Rishin today, because I was considering a sinus tarsi minimal. Now I'm pushed to open. So that's a correct way, because the future probably lies in what Rishin says. So the steps of sinus tarsi approach for intra-articular displaced fracture calcaneums are: first we do a good exposure, then we start with articular exposure, then we correct the varus correction of the heel body of the calcaneus, then we do posterior facet elevation, the height of the posterior facet, and then we do a definitive fixation, and then do closure. So these are the simplified steps which over a time, by evolving myself from doing extensile lateral approach and then going to sinus tarsi approach. So these are little bit different than what all the books and literature says, but these are very simplified. So these steps can be done, and calcaneal anatomy can be restored in say most of the 70-80% of the cases, which in a person who is starting into fixing this should select elementary kind of cases. So this is a first case. This is an intra-articular displaced fracture with a posterior facet which is gone inside the body. The calcaneal height is reduced, and there is an intra-articular component. This was operated using a sinus tarsi approach, and this is what my final fixation was, right? So I'll take you step by step how I did this. So that's my OT setup. Patient is in a lateral decubitus position. I am operating from the opposite side. The IATV comes from the front at the angle. And the first step is to visualize the intra-articular views which are required during surgery. And that when we start the surgery, before we actually inflate the tourniquet, we need to see, we can see these three views. The first is a lateral view, good Harris axial view, and a broad end view, right? So this is my incision. My incision is bit longer than what is usually been advocated, and it is bit obliquely going down toward the calcaneocuboid joint, because I believe most of this case has a fracture going into anterior process into calcaneocuboid joint. So if we take it little down, then we can actually visualize that part also. So this was the initial skin marking, and then the subq, and the first thing which we identify are the two peroneal tendons, so that once we identify that, we can protect it well. Then we gradually start dissecting anteriorly into a sinus tarsi approach, where we do a clearance of the soft tissue, then the muscle, abductor muscles, and the sinus tarsi fibrophytity. That way, we start seeing that. And then I create a soft tissue tunnel in between the lateral wall of the calcaneum and the body, which is tunnel for the placement of plate. So if I do my dissection at the start, that step has electronic plate. At this stage, I need to release a calcaneofibular ligament from the calcaneal side. I don't cut it, because if I release from the calcaneal side, it will heal again. So that's the exposure. See my intra-articular, any of the blunt. If you can see my cursor there, if you see cursor there, that's a fracture part which the posterior reducing it now. In this case, I hit the joint using a laminar spreader. lamina spreader between talus and the entry. Can use the hinterman, which will be shown in a simply use a simple retractor too. That's the an intra-article which is done. Once that is done, that is transfixed with the K-wire. Usually I use 2, here it is 1. So once the posterior facet and the posterior articular block is constructed, that part 1 is over. After exposure, the articular reduction is done. Then the second part is a correction of heel varus. I simply do my correction of heel varus using a 3 mm K-wire, which goes from the back of the heel to the body. When it was halfway, then I correct the varus with the force of the drill itself, and then I put my wire anywhere into the midfoot. Like say here it is going into a calcaneocuboid joint. So that will correct my heel varus. And the next step, I will use the same to elevate my posterior facet. So now I'm putting laminar spreader between the which is fixed with the K-wire and which is down there. If I use my laminar spreader in this wire, then probably I'll break calcaneal wall, inferior wall. So this makes support on which I can do my in this small clip. How nicely it is being elevated. Then once that posterior facet is elevated, then I put a transfixing wire, which is a threaded 2.5 mm K wire, which goes from the body into the subtalar joint. And at that time also I put my
YouTube में आपको चलते रहेगा.
At that time, you know, when I'm putting my 2.5 mm K wire, when it goes through the body, again I apply some varus correcting force. So the varus correcting force is used second time, and then I transfix my subtalar joint so that my height is maintained. Once that is transfixed, I can remove my laminar spreader, and now we can see in the third right slide that the posterior facet is now not going down. So that's how laminar spreader, but height is maintained. So that's my varus facet. So at this stage, my overall anatomy of the calcaneal is corrected. Now it is a surgeon's choice whether to go only with the K wires, or as Risin said, only with the screws, which we can do, or what I do usually is a plate fixation, right? So at this stage, the correction of overall anatomy has to be recreated. So now I use my soft tissue tunnel, which I have used. I use plate, and then I slide my plate through the sleeve which I have created into the soft tissue and put it inside. Initially, I size that plate by putting it just over the skin and seeing under CM. That's how I put my inside the tunnel, and first screw which I use is a compression screw, which is a partially threaded screw. And why I do that? Because I can put my plate flush to the bone when I compress that screw. At the same time, I can compress my intra-articular portion also. So once that is done, I start fixing with the locking screw. Usually for the apex screws for the body, I don't do only percutaneously. I do a small apex incision, like a kind of a part of the extensile approach, and then I put all the screws one by one. And lastly, I will replace my partially threaded cancellous non-locking kind of a screw with a locking screw, because my job is done. If I add a one locking screw, then I can add a stability to it. So that's my final picture of the recreated calcaneus, where we can see a nice posterior facet, articular reduction, and that's how I close, right? So that's the final fixation picture. All the views, a lateral, a broaden, and the axial view, and there is an internal rotation, axial kind of a view. So that's how I do. That's a step by step. Now what I'll do next is I'll present a video, which is a different case. So the case is, she's a 19-year-old girl, fell down from a height, and she had actually fractured both the calcaneus, but I am demonstrating the left one. So these were the pre-operative imaging. So if you look at the X-rays and the CT scan, there is a displaced Sanders kind of kind of fracture with a wide gap at the posterior facet, and this was the post-operative picture which I created. And these are the pre-op as well as the post-operative CT scans, wherein we can see that a nice intra-articular reduction, no step at the articular part, and there is a good elevation. So almost a normal kind of geometry is created. So this was the introduction of that case. I'll unshare first to come out of my PPT. Then again sharing myself for the video which I am going to do. Is my video visible?
Yes, sir. Please go ahead.
So that's the case which I just spoke about. So these are the pre-op images where there is a posterior facet broken into half. Usually we see this fracture, there is a fracture line which exit into anterior process of the calcaneum. These are the trolley and there's a different type of the plates which we keep ready. We usually do this in a lateral position with a tourniquet. So these are my marking. That's my incision which I use. I don't go beyond the tip of the fibula or lateral malleolus posteriorly. And that's an apex incision which I take. So that's a incision. As soon as I do a skin and subcu, I first find my peroneal tendons. Sometimes we can see the anterior branches of the sural nerve over here. And if we look, if we see them, we need to protect it, but I don't hunt for that. That's an anterior process of the calcaneum, which is now visualized. I am clearing off the content of the sinus tarsi and the adductor muscle and fibrofatty tissues from there. That's my posterior facet started being visualized, and that's a peroneal muscle which I look for. I usually decompress and open both the peroneal tendons. That's one, and the second will be just beneath that. So once I see that, then I just remove that septum, because anyway I am going to put a plate over there. Now that's a calcaneofibular ligament, right? So some people simply cut it, but I feel that if we erase it from the bone on the fibular calcaneal side, that's a good chance that it can heal again. So that's a calcaneofibular which I am releasing from the calcaneal side flush to the bone. Now I distract the joint to visualize my intra-articular work. So I'm using hinterman in this case. The previous case I used the lamina spreader. So that's a 2.5 mm pin into Talus, and that's an hinterman. Now the second wire will be into an anterior process. Sometimes that is broken. You can use a large hinterman, one which is designed by Rajiv Shah sir, and you put it into the calcaneus body also. So once we distract, we can see the posterior facet, the fracture and the articular part. We clean the clot and everything from that, give a wash there. And once things are clear, we use blunt instruments to reduce that, right? And I use artery, or here I use a small scoop and this bone pusher, right? Once the bone pusher, the articular reduction is okay, I use 1.8 mm 2 wires. Why I use 2 wires? So that we don't rotate on that. So these are the 2 wires. So my first step of doing intra-articular reduction and temporary fixation is done. At this stage, now the joint distraction is no more required. So I'm removing my hinterman. Removing the wires of hintermans, because now no more it is required. So how beautifully we can see the posterior facet and articular reduction. Now I am creating a apex incision, which I take as a small part of the extensile lateral approach. You can see where my apex is with the artery, and I take the flap like we are doing that extensile lateral approach, like a plastic surgeon erasing their flap from the bone, flush to the bone. It has to be full thickness so that soft tissue complication doesn't happen there also. So create a tunnel of soft tissue from both the sides, one from the body side and then one from the above side also. For that, I can use a sharp, small periosteal elevator. And we have to see that because there is a very flimsy lateral wall. Sometimes we can go inside the wall. We have to take care that we remain outside. This is how I have created a tunnel for my plate fixation. Now I will do my varus correction. This I use a 3 mm K wire passing from the body, that I will, once it is through the body, I will do a valgusization of that, and then I forward my K wire into the midfoot anywhere so that it is fixed to some normal bones. I can rely on them. So now then the second step as I described into the PPT, that I use a laminar spreader and elevate the posterior facet of this. And I take, help of the K-wire which was there put for the virus correction, because on that we can actually solidly elevate. Otherwise, the inferior wall would break. Again, posterior facet fixing wire, that's a 2.5 threaded wire, which you can transfix. You may not if it is a strong bone. And so once that is done, then there is an anterior process fracture also that I've reduced with the anterior part of the incision, put a temporary K-wire till my plate is fixed. So at this stage, my calcaneal anatomy has to be, normal. If there is some bump, I can simply punch it out so that my lateral wall is flat. You can see these all the intra-articular almost, a normal kind of a calcaneal is made there, right? Now I put my plate, pass it there into the tunnel which I have created. That's how I put my plate, and that's apex where the plate is now coming. I put a temporary K-wire, check under IITV, everything is right, and then start fixing it. So the first screw which I use is a partially threaded screw, but still I use that screw through the drill sleeve only, because that a future locking screw is to be put. So once that tunnel is created, I put a partially threaded 4 mm CC kind of a screw, which goes on a guide wire. So that's a screw which I use, and you will see the effect how this screw actually make the plate flush to the bone. I've taken little extra time on this, because if you see that the plate will so nicely compress itself to the bone, so there is no lateral one. At the same time, if there is some intra-articular compression required, that also can happen. And that screw is kept till the last. Then all the interior process, posterior facet and the body locking screws are put initially with the power, then tighten with the hand screwdriver. We can use a small spike behind the for the putting the posterior most screw, retracting the calcaneofibular which was already cut. We need to go there because posterior screw is difficult without calcaneofibular. Again, see, the plate is little off. What I am doing is with my spike, I make a plate flush. There is an elasticity into the plate, which if you do this way, at the end when you remove the wires, it can add to your heel valgus. That's how it is fixed. One by one, all the screws are put. Then wires are removed once I am satisfied. Lastly, I'll remove that screw, because the job of that screw was compression, but that will not give as good stability as the locking. So it is replaced with the locking screw at the end. And then all the things are cleaned well. We can see that if we use a plate, this much of the subtalar motion which is possible with the inversion, eversion is possible. So at some time, not fixing a plate would not give this benefit of mobilization. So this is a post-operative picture, and that's how I close in 2 layers. Sub-Q I use undyed 2O vicryl, and at the apex sometime I use that apex sutures which are a modified plastic surgeon kind, Algover Donati kind of a suture which we use commonly in a extensile lateral approach. I try and keep my knots outside of the middle bridge of the skin, taking every small care to prevent a soft tissue complication is probably the first aim in operating upon calcaneum. It is better not to operate than to do any soft tissue complication, as Risin said. So that's apex suture, which we take, Algover Donati kind of a suture. That's how we finish the surgery. And usually, the soft tissue problems are not very, very common if we do meticulously. These are the post-operative X-rays, and these are the post-operative CT scan too, showing the nice intra-articular reduction. The post-op, I use a back slab for 2.5 months, but I often to do subtalar and ankle motion. And usually weight bearing is allowed around say 2.5 months or so. That's what my protocol is. Thank you.
Thank you, Kashyap sir. Excellent video demonstration. Now we have 6 minutes for some questions and answers. I can see your first question. How will you assess a reduction on table? So, Rishin, any of your tips to assess reduction intraop?
Yeah, again, with an open approach, you're kind of directly visualizing the subtalar joint, the posterior facet. So I'll sometimes take a freer, and I'll kind of take a freer across the subtalar joint to see if I feel any kind of, divots or any kind of step offs. So, using an instrument that's not going to damage the cartilage aside from visualization. Again, the three views that Kashyap mentioned, Broden's view to see the posterior facet under fluoroscopy. Harris heel axials are crucial. I think the combination of direct visualization of the joint itself and radiographs for me are how I kind of assess. Sometimes I do get contralateral films if the anatomy is weird, just to kind of see what their height is like on the other side. But for the most part, restoring the posterior facet gives you connecting that to the anterior part gives you a good idea of what the height needs to be. So.
That's a great point. What he said is a combination of direct visualization and radiological views, both. But you see, intra-articular part best visualized intraop if you're opening it. And he said all the components like intra-articular step, varus, valgus, length, height, that is what is more important. So those are great points. Kashyap sir, I want to ask you one question. Now, Rishin was very clear when he is going to opt for MIS and when he is going to opt for open. So I want to ask you, when you are not going to have this sinus tarsi in your cases, when you will not opt for sinus tarsi in your cases.
Yes, that's a very good question, and probably partially that was answered in Rishin's talk. If there are some medial procedures to be done, say it's an open fracture, or if there is a sternocleium tali fracture which is fixed, then it's done from the medial. And second thing which I would do is, if there are some cases which needs a primary fusion over and about to fixation, so that's not the case for sinus tarsi. Thirdly, the sinus tarsi is not the direct approach which anybody is going to jump and do it. So a surgeon has to evolve himself from treating a simpler calcaneus fracture with extensile lateral approach, then treating complex fractures with the extensile lateral approach, and then going to using a sinus tarsi to a simpler fractures. So if there are any complex cases where we need to put a lot of bone graft, primary fusion, or if there is any doubt, see, my advice to, in all the fractures, we should not marry to one thing. We should not, keep our ego high. So we have to be open to the things. But that's a very much personalized, because if now I have got a case of Sanders 3 or sometimes 4, I can go with the sinus tarsi. But for people who are starting, should go with the young patients, less comminuted, intra-articular Sanders type 1 or at the most 2, and should have some exposure to the extensile lateral approach when they are done.
Yeah, very well said. So that don't get married to only one ideology. We should be open, and particularly in calcaneus fracture, patient factors and even surgeon factors, injury factors. These three things are important. What injury needs, what patient as a comorbidity needs, and what surgeon knows. Rishin, I had one more question. You said sometimes that a lady would have come to you in emergency, you would have put her in fixator. So
Yeah.
typically external fixator, if you put day one as a spanning fixator, how many days you would not be, you would be very comfortable that you won't have any pin tract infection subsequently? Because when you're going to do some sinus tarsi or some open technique, you're always worried about those pin tracts.
Yeah, that's a good point. It's a great question. I don't think there's a true science to it. When we fix comminuted, severe pilon fractures or distal tibia fractures, we'll put these patients in X fixes, and we do our best to not span the our plate with the potential pin site, so put your pins proximal. But there's not a lot of literature that supports that. It's kind of more just the thought of, hey, it makes sense, right? But In a calcaneus, it's tough. I don't put X fixes a lot on calcaneus acutely. The main reason I would do it is, let's say the patient, a lot of times these patients come in, they have concomitant injuries. So, they'll come in, the calcaneus fracture is the least of their problems. They come in with abdomen injuries, and they're going to be in the ICU for weeks. You don't know when they're going to be cleared for surgery. So in these patients, when they go up for their acute, open abdomen surgery, putting on a quick X fix maintains the height, right? And so if you're not going to get a chance to get back to them, or if they have a lot of injuries, it helps. To answer your question, I typically will wait until the soft tissues are ready. So, I think, Kashyap had a great, the wrinkle test, seeing the skin wrinkling. I'll keep the X-Fix on until it's time, and I'll take it off at the time of surgery. So I don't do anything special for the pins or the pin sites. I kind of treat it like I would a distal tibia or a pilon.
Yeah, great. So we have utilized full our allotted time, and thank you so much, both of you. You have shared absolutely good points. I always tell my fellow colleagues, never start calcaneus case unless you see a good axial view, and never leave OT unless you see a good Broaden's view, because that tells you everything. It is not only the interarticular component, as Dr. Rishin said, it is all what you are supposed to do. And then, as Dr. Kashyap said, don't marry to only one ideology. Whatever you can do, all these things by the preferred approach, you should do it. So thank you so much for enlightening on this difficult topic. Over to the next moderator, or Raju Shah.
Thank you very
Thank
much.
you.
Thank you, sir. It was a great moderation. Thanks,
Thank
Stacey.
So, Dr. Rajiv sir,
Thank you, sir.
can I move on?
Yes, Rajiv, sir, please start the next session. Thank you.
Okay. Thank you so much, everyone. And it
Rajiv,
is
sir,
my
I think
pleasure
you've logged on to Rajiv, sir, you've logged on to two devices. Can you mute one, please?
Okay. Is it okay now?
Is it okay? Yes, sir. Better.
Is it okay?
Yes.
Okay. It is my pleasure to be part of this, interaction. And flat foot is a very, very big problem, and all of us know that there is hardly any algorithm which suits all the situations when we are facing this sort of problem. And we have two experts, one from US and one from India, who are going to throw some light how to approach this problem. And I welcome my first international speaker, Dr. Vinayak Sathe, who is an assistant professor in the Department of Orthopedic Surgery of Ancon Musculoskeletal Institute. And he's a fellowship-trained foot and ankle surgeon from Baylor College of Medicine, Houston, University of Arkansas, and he has done fellowship in sports medicine and surgery from Kentucky Sports Medicine. He is also a fellow of the Royal College of Surgeons of Edinburgh and fellow of American Academy of Orthopedic Surgeons. And he is one of the top doctors on the list of Hartford magazine. And his main focus is on all foot and ankle disorders. And his today's topic is approach and algorithm on flat foot reconstruction. And I request him to make this, the whole process and the algorithm a little simpler so that we can understand how to approach this complex problem. Welcome, Dr. Vinayak Sathe.
Thank you very much for inviting me today. And it has been a great talk earlier, so I hope I can keep up to the standard. Can you hear me and see my slides?
Yeah, we can hear you, definitely. So
Okay,
you
so
just
I think,
put in the slide.
Yeah, sure. So I was given a topic for approach and algorithm to flat foot reconstruction. And again, it's a pleasure to talk on this topic. As you know, most of the foot and ankle surgeons do see this patient probably every now and then in your clinic. And it's, as you said, it's very complicated in the sense that how do you approach this? So the way I decided to decide to talk on this was to just give a brief history about adult acquired flat foot deformity, which was the original term that was used. And then now, as you know, the last couple of years, the term has changed to progressive collapsing foot deformity, or PCFD, and you will probably hear more of this term in the future. So I think the PTTD was the older term, and then it included the positibial tendon dysfunction with the adult acquired flat foot. So going back to how it all started, back in 1989, Johnson and Strom classification, everybody's probably familiar, and I just want to repeat it. It was
Satesh sir, sorry to disturb you. Just can you put it in full screen?
Sure, of course, yeah. Just doing it now, hopefully. Can you see me now at the full screen?
No. Yeah, now it's right, sir.
Okay, thank you. So Johnson and Strom decided, or rather classified in 4 stages, the flat foot deformity. Stage 1 being very minimal tendon problems with no deformity, very early stage. Stage 2 was all flexible. Stage 3 was rigid, which is basically arthritic stage. And then stage 4 was added by Meyerson, where the ankle was involved with valgus because of this continuous flat foot deformity. So this is, as you know, is a progressive disease. It starts probably from stage 1, but it may not be necessarily going adequately up to stage 4. Sometimes it halts in between. Now, multiple regions, multiple joints are affected because of this deformity. And because of that, all the deformities had to be described in particular stage. This new classification was introduced, and I just wanted to let you know about that. Now, before we go there, I just want to touch base about flat foot. How do you approach it? And I was kind of more interested to say that there's differential diagnosis for this, which everybody should be aware of. And as you all know, unrecognized Lisfranc injury is one of the most important things that you can see, where the Lisfranc injury is not seen or rather missed, and you can end up getting a patient with a flat foot. Similarly, midfoot arthritis, Charcot's, peroneal spastic flat foot, including tarsal coalition, accessory navicular bone, and then spring ligament tear and deltoid ligament, which is part of the regular flat foot deformity. So this is just a Lisfranc injury which was missed and may come as a flat foot to you. So just be aware of that. Similarly, midfoot arthritis, again, will come to you as a midfoot arthritis or other flat foot deformity. And again, this is not your classical positibial tendon tear. So again, you have to be aware of it. This is a Charcot patient where you have midfoot collapse. People being diabetic come with flat foot deformity. So be aware of that. Everybody has seen this tarsal coalition, anteater sign, and this big coalition where it can present as a flat foot. Similarly, all the accessory navicular types 1, 2, and 3 may present as a flat foot. So I think these are the things you should be aware of when you're dealing with flat foot. Now, coming back to the new classification, which is the progressive collapsing foot deformity, it has been described in 2 stages, which is stage 1 flexible and stage 2 rigid. And then it has been described in 5 classes. So basically, class A is hindfoot valgus, class B being the midfoot or forefoot abduction, class C is a forefoot varus deformity, class D is peritalar subluxation, and class E is ankle instability. So kind of a new classification in form of stages and classes. And you can see that the class A, which is hindfoot valgus, may be in stage 1, and then the class C may be in stage 2. So that's how it is described, and you may see more of that. So it's a complex deformity with different planes causing different deformities, including the coronal, axial, and sagittal plane, and it may present in different varieties. So those are the things that we earlier mentioned about the classes, which are what they have been described. So progressive collapsing foot deformity is a complex disorder, and basically it is due to medially positioned soft tissue structures, ligaments being stretched out along with the positibial tendon, which may not function very well. So deformity eventually leads to bony problems and then arthritis. So basically, it has been described with various stages, and I'm going to kind of go more further into detail with those. So this is a classical exam you all see in your office where there's a fixed deformity, and including, you can see this classical flat foot, classical supinated foot, as well as basically too many toe signs. Typically, when you see from the back, you'll see that there is inadequate indicative of the forefoot abduction, where you'll see too many soles on one side, along with the heel being in valgus as compared to the right side. Also, you have to look for tenderness. So when I'm approaching these patients, I want to see where the pain is. Sometimes the pain is medial, and then in later stages, the pain shifts laterally over the sinus tarsi. So patient may tell you that the pain is not medially, but it's all lateral. And that's because the heel has gone into valgus and there is impingement of the peroneal tendon between the distal fibula and the calcaneus. You can also have to do a single leg raise, as you know, because you have to check if the heel deformity is rigid or is supple, and if the patient can do it, or if there's any pain, and that gives you an idea about whether the tendon is functioning or not, and accordingly you can plan surgery. The other thing very important when you are approaching or fixing flat foot deformity patients is the silver scale test. It's basically a test to check whether the Achilles is contractured or just the gastroc, and what you have to do is you have to supinate the foot to lock the midfoot, and then the only motion occurs at the ankle joint, and then you have to check how much ankle dorsiflexion they get with the knee extension and knee flexion. If the knee flexion, dorsiflexion goes more, then most likely gastroc having come from above the knee would be contractured, and most of the surgery in flat foot does involve gastroc release. I also do imaging, and everybody's familiar with those. The standard views, ankle, foot, as well as Saltzman-Kobe view. They are all weight bearing with the knee extended to get your correct angle before you plan surgery. And then you can see all these three criteria, which everybody is familiar with: the lateral talometatarsal angle or the Meary's angle. And we talk about negative Meary's angle, where the talus is plantar flexed. The calcaneal pitch angle being to see how much pitch angle there is, or is there a flatness to the heel. And finally, the medial cuneiform to the floor distance to see if there's a midfoot collapse. There are several angles described. One of them would be the talonavicular coverage angle, and it is important to decide how much there is coverage before you can consider surgery, whether you want to do a lateral column lengthening or not. The new things that in imaging could be, and we don't have it in our institute, but weight-bearing CTs, you'll see that is being increasingly described, along with the MRI scan, which is not as commonly done, but weight-bearing CT definitely is going to be more used. And I have myself had experience where I thought patient did not have arthritis. I did treat the patient for flexible, and then I think eventually in 2 years they did get arthritis. So I think weight-bearing CT is going to be more and more used along with the MRI. So I've got a few cases here. I think I just want to show you. So this is a 43-year-old female with 2-year history of right medial hindfoot pain. And she was worse with increased activity, atraumatic, so obviously no injury, always with a history of flat foot since she was a kid, and she works in retail, as well as she has had no treatment in the past. So when I looked at her, she had standing alignment. She had bilateral hindfoot valgus, more pronounced on the right, and the collapse of the midfoot. So she did have collapse. She had a bilateral heel valgus more on the right side. She was tender on the posterior tibial tendon at the level of medial malleolus. She was passively correctable. And when corrected, the flexible forefoot. So again, this flexible forefoot supination is important to see whether you need to do any cotton fasciotomy or not. So she was unable to do single leg raise, obviously due to pain, and she was weak on plantar flexion inversion with a positive silver scale test. So these were her x-rays, and you can see that she is right now has a Meary's angle, which is negative. She has got a flexible foot, but basically she is tender over the posterior tibial tendon. These are her x-rays of the ankle, and you can see the heel valgus obviously going more on one side than the other. So I think what I look for when these cases would be, where is the tenderness? So the tenderness is the posterior tibial tendon at the level of the medial malleolus with weakness. So how would you address that? So standing alignment, x-rays were done, collapse of the midfoot is there, she is flexible. And then so for that reason, I would definitely do an FDL tendon transfer. So the way I approach it would be that if there is tenderness of the posterior tibial tendon, obviously you have to expose the tendon, debride it, and most likely this lady will get an FDL tendon transfer. If she has got a hindfoot valgus, which is more pronounced on the right side, then we have to address the hindfoot valgus. And most commonly done osteotomy will be the medial sliding osteotomy of the calcaneus. Sometimes you have to see how much slide she has to, typically up to 1 centimeter is what she would need to correct her hindfoot valgus. So I think, so hindfoot valgus will be addressed by doing the calcaneal slide. Now, last thing would be the silver scale test. How would you deal with that? And as I mentioned earlier, the gastroc release is what you would be doing if the ankle dorsiflexion is improved when the knee is flexed. So depending on the silver scale test, she will also need a gastroc recession. So I think basically what we are looking here is where are the deformities located? Are they flexible? And then according to where the symptoms are, we address individual problems. And you can see that the calcaneal osteotomy was done, and she did pretty well after the surgery. I'm sorry. So she also had an FDL tendon transfer to the calcaneal, to the navicular. Now in case 2, I think what I want to show was basically everything was the same, except that when you correct the hind foot, when you do the medial displacement calcaneal osteotomy, tendon transfer, gastroc release, the forefoot is still in supination. So how do you basically deal with that? So in that case, you either have to do a lapidus fusion or a opening wedge medial cuneiform osteotomy to bring the first metatarsal down. So I think once you correct your other deformities, what you need to check would be the supination part of the foot. You can clearly see here that it needs to be corrected. And in that case, either in this particular case, I did a lapidus fusion as well as the FDL tendon transfer. The other case I had was a 14-year-old young lady. She had knee pain. It resolved with orthotics. Basically, the orthotic did help her during kind of day-to-day activities. She used to play soccer and had knee pain. But more importantly, she had bilateral hindfoot valgus as well as forefoot abduction. So basically, she had too many toe signs. She was able to do single heel raise without pain, and the hind foot fully corrected. So I think she probably does not need any osteotomy. So no pain over the posterior tendon. So basically, she had no pain, so the tendon was functioning, and the silver scale test was positive. So she is again a young lady. These were her X-rays, and basically, and she's almost about to stop growing. So how do you deal with these patients? So bilateral hindfoot valgus and forefoot abduction with too many toe signs, able to do single leg raise. So the posterior tendon was intact, hindfoot fully corrects, no pain, and then silver scale test. So basically, for these patients, I typically will do a lateral column lengthening procedure, and that's because the hindfoot is in valgus. And to correct that, I think lateral column lengthening would be more ideal to bring the foot more into anatomical position. Because she was able to do single leg raise without pain, so again, I think the message is if there's no pain of the posterior tendon, you don't have to necessarily address that. So there's no need for a FDL tendon transfer. And the silver scale test, I think I addressed that with a gastroc recession. So basically, if you have a tight gastroc, then the gastroc recession needs to be done. And here in this case, we did a lateral column lengthening to bring her arch back, make the calcaneal pitch angle normal. And so basically that was what was done. Case 4 history. This is a 55-year-old female with progressively worsening flat foot deformity and left foot pain with no issue of trauma and pain over the lateral foot. She's a retired lady. She's obese. She has bilateral hindfoot valgus, worse on the left. She's unable to do single heel raise due to balance, and tenderness over the sinus tarsi in the subfibular region, and no pain of the posterior tendon with a rigid hindfoot. So as soon as you hear the word rigid, I think the algorithm here is basically, you can see here, the foot is pretty much stiff and it's not really much mobile. So I think the answer to this would be a triple arthrodesis. In this particular case, I use screws across the subtalar joint, talonavicular joint, as well as the calcaneal cuboid joint, and that basically helped her out. So this is case 5 history, basically 50-year-old female with left medial foot pain for 2 months. She works in retail and worsening pain after being on her feet, never with having any similar episode before. She had bilateral hindfoot valgus worse on the left. She had some pain with the single heel raise, and she had pain on resisted plantar flexion inversion and pain over insertion of the posterior tendon. She had a flexible hindfoot, and the silver scale test was positive. Here are her x-rays, and here are the x-rays again of the AP and oblique view, and then this is a lateral view. So basically, in that particular case, I do not have the x-ray, but I think we ended up doing basically a flat foot reconstruction procedure where we did FDL tendon transfer and then addressed her heel valgus with calcaneal osteotomy. The next patient is a left medial foot pain. She's 66-year-old. male, sorry, with acute onset pain over the medial foot after motor vehicle accident. There was pain and swelling immediately after the injury. He started noticing progressive collapse of his foot, and he failed orthotics and Arizona brace. So 66-year-old with an acute onset medial left foot pain after motor vehicle accident. So physical examination showed a hindfoot valgus on the left, collapse of the arch, tenderness in subfibular region, tenderness under the plantar TN joint. So that is kind of the pointer here, that there was tenderness here with a supple hindfoot, and he did have some power in the posterior tendon and was able to do single heel raise. So I think this is a scenario where there's a spring ligament tear, where patient had acute onset pain, very quickly developed flat foot deformity with a heel valgus, and they were tender basically under the plantar TN joint. So these are the x-rays, and really nothing really showed much apart from that. So the plan for this patient was a spring ligament repair and reconstruction, medial calcaneal slide, gastroc recession, and cotton osteotomy. So this is just a slide to show the spring ligament repair, how we do. Once we expose medially, do remember the spring ligament runs from the sustentaculum tali to the navicular bone, and it is like a hammock. It supports the talus and stops it from going into plantar flexion. So initially, I put in the anchor in the navicular bone, and then basically, if you find the other end of the spring ligament, sorry? Yeah. So once you find the other end of the spring ligament, you can repair it directly. But a lot of the time, I use a tendon allograft, basically because it helps me give more security. I've also started using an internal brace recently, which is also like a fiber wire suture. Here I am putting my drill hole into the sustentaculum, which is the footprint of the origin of the spring ligament, and then basically repair the ligament with the anchor on one side and the other side in the sustentaculum tali. So you can see that. And then finally, once you do that, if you still have to do the FDL tendon transfer, you can still do. This is the cotton osteotomy done for the patient. And this is the final result. Let me just go through quickly another set of screens. So sorry about this.
So,
I think that's what I have today. Yeah.
okay. Are you finished there?
I'm just going to check if I am missing any slides here. Just give me 2 seconds. Yeah, I think I went through the cases, obviously. And yes, I think pretty much done. Thank you. Yeah.
Thank you, Dr. Sate, for this wonderful talk. And I think you have really highlighted whether we need to understand actually where the deformity is, what is the actual problem, and the problem need to be solved according to that, whether there's hindfoot valgus, midfoot abduction, and tight TA, residual supination, whether there's impingement or not. And now I think we can take the questions later on. And I would like to invite our Indian faculty, Dr. S.M. Ajoy, to give the Indian perspective of the flat foot reconstruction. And it is my pleasure to introduce him. He's a senior consultant in foot and ankle services at Ramaiah Medical College, Bangalore. He's a fellowship trained surgeon in foot and ankle surgery from National University Hospital, Singapore, Switzerland, and is an associate editor of Journal of Foot and Ankle Surgery, Asia Pacific, and is also a former secretary of Indian Foot and Ankle Society. Apart from that, he has interest in tissue banking, and he has done his diploma from Barcelona, and he is coordinator of the Ramaiah Tissue Bank. He has been faculty to many AO and allied courses and has many publications to his credit. May I invite Dr. S.M. Ajoy to give the Indian perspective, and then we can take the questions later on. And I request the audience to put the questions into the chat box so that we can take these questions with the respective speakers. Dr. Joy, please, over to you.
Thank you. Yeah, thank you so much for that wonderful introduction, and thank you everyone. I feel quite honored being here amongst teachers and mentors who have actually helped me pick up my threads about foot and ankle surgery itself. Now, at the outset, can I just play a short video? This is from the
It's video on.
This is a video. This is the welcome video which has come from Dr. Rajesh Simon. Is this visible?
So, I think we all
please
are
share your
looking forward
screen.
to the
Yes, sir.
Ifas coach. Yeah. It's not starting yet.
Just sir, otherwise you can share the video in WhatsApp. I'll share the video from my end. No worry.
Okay, right.
Please go ahead with the talk, and then we can, even in the end, we can play the video after the talk if you want.
Okay, fine. That should be okay. Yeah, is this visible? Slides and
No, slides is not visible. Your screen is not visible. Please. It's still not visible, Dr. Joy.
yeah, I'm trying to do that.
So can you start screen sharing? Just click on share and then say screen.
Is it visible now?
Yes,
Okay.
it's coming. Yeah, it's come. Just go to the first slide, sir. Go full screen first slide. Yes, sir,
Okay.
perfect. Thank you.
Right. Okay. So thank you very much, everyone, and let's move on. I think Dr. Sathe has shown us a very wonderful presentation with regard to the flat foot itself and how do we manage these patients. Now, when we are looking at patients, we might see some of them who are in this state, some of them with a collapsed arch. This is a 32-year-old lady whom I'm just showing, and that's the arch collapse which was there and could be identified very well to be coming from the midfoot itself, from the hindfoot itself, and that of a younger adult, 26-year-old boy who's having a rigid flat foot. So would we be able to treat both of them the same way? That's not going to be the same, isn't it? So we are going to always try and aim to see that we get a proper correction of these patients. And this is something which is very desirable for us. But would we be able to achieve this in each and every patient? So that's what we're going to look at over here. This is the brief overview. Let us look at how, in the Indian perspective, how common it is to have flat foot. Are all of these patients who are there having flat foot symptomatic? How do we image them? We don't have weight-bearing CT. How are we going to image these patients? What do we have an algorithm for treatment? And based on the literature that's available, and a short surgical video as to one of the procedures for pes planus which I do perform. So we actually looked at the incidence of flat foot here in India. So among the 14 to 16-year age groups, what we noticed was that almost 33% of these children were having a pes planus. Fortunately, 90% of them were flexible and 10% of them were rigid. But then it does amount to a very significant number of patients if they actually come with complaints. We always start examining these patients with the same way. Then we first look at the footwear. When we look at them, we know that the footwear is worn out on this side, indicative that this patient is walking more on the medial aspect of the foot itself. We look at these patients, inspect them completely, look for the two-minute toes, look for the hindfoot valgus, and then also we check to see if these patients are flexible or rigid. One of the ways of checking this is to perform a JAX test, wherein you can see that by just gently dorsiflexing the great toe, we are able to recreate the arch in this way, in these. not everybody would be able to perform a single heel raise. So we might go with a double heel raise test initially, and then on try to identify if this whole flexible flat foot is a reducible one. So if you give gentle pressure onto the talar head and see, you might be able to reduce this patient and recreate an arch without actually allowing for a weight bearing in this patient. So this is something which we can always assess even on the table to see if this flat foot is flexible and if there's a tight tendoculus or a gastroc associated with it.
Are we having connection problems?
So, are you not seeing? Is everybody able to
Sir,
see?
everything
Now,
is clear. Everything is clear, sir. It is fine.
yes, yes.
Please go
Okay,
ahead.
okay.
Right.
Sorry. Okay, right. And this is a like a clock analogy to see what would happen in case the tendoculus is tight and it is short. So we would end up with something wherein the hands of the clock, you can see that the talus and the calcaneum are pulling at logarithms to each other, and that is what we can see in these patients when you examine the hand foot itself. Standard imaging is required. As we go ahead, we can see that the AP standing and the AP lateral and the standing lateral images are there, indicative whether this patient is having a collapse of the arch and whether the Meary's angles are maintained and where the pitch is. Salzman views, of course, can be very informative. And these patients, we always get to do a scanogram to see if there is any issues higher up, if the patient is developing any deformities proximally also. Indicators for getting an MRI done is tenderness on the medial side to see if the spring ligament is intact, which is being shown on the slide on the left, and to see what's the status of the accessory navicular. Very often patients do complain of pain at that region, to see if there is any reaction there, and that is one of the sources of pain on the medial side without causing any tear in the tibialis posterior tendon. This also, of course, can be imaged by getting an MRI, and you can see a torn tibialis posterior which is retracted over there. Now, in the Indian scenario where we don't have access to a weight-bearing CT, it is very easy for us to repurpose what the fluoroscopy machine. So this fluoroscopy machine is used in the radiology department for imaging, for barium studies, and for all other motility studies, and also for IVUs. So what we can do is tilt this table and get the patient to stand there, standing on one leg, and ask them to see if they can correct themselves or they cannot correct themselves. So most often these patients have got some amount of a flexibility, and that can very well be established by tracing these patients' talus to see how well it is moving. This is a continuous video of this, which I have not been able to insert, which is the reason I'm showing this. Now, this was introduced to us. Dr. Sati introduced this topic of having the different nomenclatures available now, which is the most common nomenclature is that of a progressive collapse and foot deformity, and the classification which went along with it. And very often you see that if there is somebody who is flexible, who has got a peritalar subluxation or dislocation, and is not having any subfibular impingement, I think those are patients which we can pick and perform simple, minimally invasive procedures wherein we are able to address them. A review that was in 2024, very recently, and in the month of February, we had an article coming up wherein all the classification systems for acquired flat foot have been reviewed, and these patients, and they have come out with a three-column 3C classification, wherein we are able to classify these patients. But then all of this classification, if you can see, is in conclusion, after performing the review, what they have mentioned is that it allows the feet to be typed, deformity to be zoned, and ligament laxity to be staged. But then this is not in any way going to aid us in designing and determining what kind of a surgery this patient would be requiring. So should the approach to the management involve? It should involve to check if this flat foot is flexible or not, if there is a site where the site of the collapse is happening, if the medial structures are intact or not, which has been clinically achieved by checking for tenderness and checking for the reduction of the talar heads. Then we are looking to see if there's any lateral impingement that would also determine what kind of procedures we perform. If there's a midfoot abduction and it can be corrected passively, that also can be checked. If there's a forefoot which is either in a valgus or a varus, all that can also be assessed. and the presence of arthritis, which would entail us to go ahead with planning for fusion procedures. But what I do feel is whether the severity of the pes planus and the age of the patient, do these help us in any way to determine what kind of surgery we perform? Is it possible for us to extend indications towards the older age group? That is what I've actually been debating. And we are also performing a study comparing two different procedures, where one against vis-a-vis the other. An adult patient, she is around 60, but she is having a pes planus whom is now very symptomatic. She's got pain predominantly on the medial aspect, but then if you can see, that's how she stands. That's her hind foot, which is going to valgus, but there aren't too many toes which are visible for her. And she was flexible. It's the same patient I'm just showing. She was flexible. And when we took her, these are her X-rays. You can see a collapsed Meary's arch and a calcaneal pitch, which is reduced, and which is there on both sides. And on the left side is where she was very symptomatic with the excessive talonavicular uncoverage, and the same being carried on with the Salzmann also. Intraoperatively, when we did examine her, I was able to reduce this very well, and I was found that she had a tight tendo Achilles in her case. So that's the procedure being performed over here. So I do mark out we check the two bony prominences, which is one is the lateral malleolus, and the second is the anterior process of the calcaneus, which we are seeing. And the incision is placed. There are the two nerves which are marked out, the sural and the saphenous, the superficial peroneal, and midway between all of that is where the incision is being placed. This leads us directly into the sinus tarsi. So that's the plan. And for the tendo Achilles, we can do a partial triple hemisections, mark out the tendo Achilles and mark out the areas where we're going to go with the triple hemisection for this tendo Achilles itself. There are two valgus, because it's in valgus, two towards the lateral side and one towards the medial side is what we prefer. And sometimes I may even go with the fourth incision if required. So just from the midline towards the lateral is how we are going to perform the partial hemisection of the tendo Achilles itself. And at each and every stage, we're going to stretch it out to see if at the end of the three cuts that we have made, we are able to get a dorsiflexion which is adequate enough for us to sustain. So this is what was checked. And once we had performed, we could see that there is an adequate amount of dorsiflexion which was possible in this particular patient. That's the incision being performed exactly into the sinus tarsi. You can see that it's only the skin that we're going to cut. We don't have to cut deeper at all. So once the skin is cut, we utilize an artiforceps, which we can, with which we are able to dissect out the soft tissues gradually so that we are not going to damage anything for that matter. And once we've done that, you can see that the sinus tarsi which is going in, and it's being demonstrated here, is not directed anteriorly, it is directed posteriorly. So that's the way we will have to direct. So if we are going in that way, we always have to direct towards the posterior aspect. So reach out there, reduce the talus, and that's the position in which we will be going with the intended tenotomy scissors. That's the tenotomy scissors which is being shown here, and through which you can go direct this posteriorly again, and a short snip there of the interosseous talocalcaneal ligament will release and allow us to move the talus very well. A guide wire placed there to check that we are exactly in the sinus tarsi will lead us to show where we are. And imaging under the IITV will also show us. So you can see here that we are completely able to realign the talus and the calcaneus under the tibia. And this is possible. Different sizes to hold up the sinus tarsi can be checked out. So that's the sizes which are being used. So we start off with a sizer 5 mm in width, and then on assess to see if that is adequately reducing the and filling up the sinus tarsi itself. And we achieve the right amount of correction. And where to do this, we see that this spacer that we're going to use, or the stent that we're going to use, is going to lie exactly at the lateral border of the neck of the talus. And when that is being done, to see if we still have a good amount of eversion present for us, and if we have a good amount of a dorsiflexion which is there for us. So this is what we assess. And once that is done, so that is quite satisfactory. We do have some amount of an eversion. What we have done is we have only prevented the excessive eversion of these patients and have reduced the talus onto the calcaneus quite normally. That's the stent which is going into place, inserted over the guide wire. And once that has been done, you can just go ahead, perform this same reduction maneuvers just to see, put the whole thing through a range of movement, and then we're going to remove the introducer and check out. So you can see that the arch which was not there has already been formed right on the table itself. And you can see that a good amount of a dorsiflexion is possible without the foot going into an everted position. The sinus starts a stent in position, and that's the closure which is done. So it's a very minimal invasive procedure, not indicated for everyone, but only for those where we are able to relocate the talus onto it. That's the snips that we had made into the tender Achilles, which should heal up without having to do any suturing itself. And that's the correction which is achieved on the table. So I've not summed up anything. So because I wanted to lead this directly into a discussion, which is the reason I don't have a summary over here.
Well,
So
thank
stop
you,
screen
Dr. Joy,
sharing.
for the thank you, Dr. Joy, for this wonderful talk. And I think we have ample time for discussion now, 20 minutes. So let me take the questions first, which are first directed. There are only two questions which are directed to Dr. Vinayak. One is the earliest age of surgery in the flat foot. Do you have any parameters to judge at what age the surgery should be there?
So good question.
Dr.
I think
Vinayak?
I've never done anything. I don't see patient actually below 12 or 14 in my clinic. We have a separate children's hospital in Connecticut. But I think the way I deal with it is if there's a progressive deformity, let's say, and here we have American kids playing football, they are 12, 13, 14, and they are 6'4" and 250 pounds sometimes. So I think what I look for is the symptoms and also the progressive deformity. Sometimes the parents will come at the age of 14, he plays football, his foot is collapsing under his foot. And obviously they are worried that this Achilles tendon is getting tighter. So my answer to that question is a little bit in a circumvent way that I don't see anybody below 12 or 14 to be giving you an answer for a pediatric flat foot thing. But certainly for adolescent and pubertal, I think around 12 or 14, that's my indication of the arthrolysis screw. So I try to make them go adulthood till they are 17, 18. And then that's where my indication for arthrolysis screw is, along with Achilles release or gastroc release. And then I take it out at the age of 17, 18, and then treat them like a regular adult flat foot case. So that's what I usually do.
Dr. Vinayak, there was a second question, the role of arthrolysis, which is you've already answered in this. Now, coming to the age, I would like to take it further. That does the age influences your decision? Like you're getting something like 60-year-old or 65-year-old, then you joint preserving versus joint sacrificing surgery. What is how you make your choice whether this is going to be, or it is just like anywhere, same for 40 years and 65 years, 75 years.
So again, good question. I think typically, as you know, flat foot deformity is in middle-aged women and, a little bit of obesity, above 55, 60 is a normal age. And I, of course, take every case individually. So depending upon, as we discussed, rigid or flexible deformity, I usually address what is their problem. Is that a pain their problem? Is it the heel valgus? Basically, is the deformity getting worse? And what are their activities they like to do? So essentially, I like to do joint preserving procedures in a flexible case. But I have got burnt, as I mentioned in my talk, that I think with the weight-bearing CT, I've seen that some of these patients did come back in 2. I think one came back around 2 and one came back after 5 years saying that, no, it didn't work. And then when I went back, I think the CT was non-weight bearing, obviously. But I think the weight-bearing CT apparently does show more and more of these patients sometimes have arthritis, subchondral sclerosis, and they are actually one stage beyond what you think. So even though there is a flexibility, and obviously it depends on the patient's weight and age, I also tell them that I may not be able to give you a foot for the next 20 years, and that this may still progress. And eventually you may need a triple or a double arthrodesis. So again, I think weight-bearing CT is going to give us more information along with MRI, but my go-to is joint saving procedures initially, and then basically joint fusion if needed to be.
So just continuing with this joint sacrificing versus joint preserving, one of the procedures that is subtalar arthrodesis. How you actually this is to both of the speakers. The patient is having a lateral pain but is having even a flexible flat foot, and the subtalar is okay, not. So how to actually make this decision whether in the presence of impingements you go ahead with some Calcaneal slide or a subtalar. It is to both the speakers in a flexible flat foot how you make the choices between the osteotomy and the subtalar arthrodesis. This is for both the speakers.
Dr. Ajay, I want to go.
Yeah, okay. So yeah, when see if it is flexible and the joint per se is not very tender, which can generally happen. In those instances, what I do is I go with something like a joint preservation itself. It's not possible to convince these patients for a fusion on this patients at all. So I still try to preserve even if the patient is around 60 and there's no involvement of the joint, which is often common. And because I learned this the hard way, because I had actually posted a patient for fusion. Actually, I wanted to do a subtalar fusion, opened her up on the medial side because I knew that if I were going to go on the lateral side, I might not end up with a good closure. Opened on the medial side, and when I found the subtalar joint to be very, very pristine. There's excellent cartilage there, and I just didn't feel like fusing this. Then I went ahead with something like a joint preservation only in her case again.
So I think, yeah. So I think there are some outliers, as was mentioned earlier, that as Dr. Ajay nicely described as well, that sometimes at the age of 60, I also take into consideration their weight, their activity level. And and as I said, if patient is obese, and there are papers for and against it, but I've had patient where there was a pretty high BMI and pretty obese patient. And if you look at the FDL tendon, it's really like 1/3 the size of posterior tendon. I mean, when you see that FDL, do you really think in your mind it's going to work for the next 10 years? That's my question to myself. So in those patients, so my kind of go-to, I also do subtalar joint injection sometimes to see if they have any pain relief from there, or they have any arthritis or any other symptom. But there are outliers where I would fuse, especially obese patients who are really they're not going to do well with whatever you do. And I do kind of offer them triple arthrodesis or subtalar. But again, I try to do joint saving, but I think certain outliers I do fusion as well.
Okay, in the practice, you may get a flexible sort of a flat foot where you get an MRI done, you see some impingement signs, there is edema over the cutaneous and the lateral process impinging into it, and the patient has a lateral pain. So, but still, it's a flexible. How you actually, I wanted that you make your decision that is this patient to go for subtalar arthrodesis or to go for
I think if it's just edema and nothing beyond that, I would certainly do a subtalar injection to see how much pain relief they got, just to get an idea of whether it is helping them or not. Those patients, I would definitely do a medial slide just to reduce the pressure, or as you know, it's a peritalar subluxation. So I would definitely do a slide, or sometime I've also done, although not that commonly, both a slide and the lengthening at the same time, although I'm not very good at it. Sometimes you can get it. So, but I think it's like a double osteotomy so that you reduce the peroneal tendon impingement, but at the same time, the talus is located under, basically the talus is located over the calcaneus in a good position. So I think double slide, which is where the Evans and the lengthening is what I would do.
Sort of in the second case, you showed that you went ahead with the fusion of the first TMT joint.
Yes.
And big was the residual supination. What was the actually reason that you decided between the cotton and the the first TMT fusion? What was the reason that you went ahead with the TMT fusion?
So if I remember correctly, and I've done a few of the, I think if I remember correctly, I typically will do even pre-op, but also on the table, the instability test, the tarsometatarsal instability test. And if there are two lags, then I usually would do a fusion. So if I remember correctly, and I do it in every of my patient, that I will check that joint to see if it is, and then if it's unstable or very lax, then I prefer a TMT fusion. Sometimes I've even done a whole medial column fusion if they're really unstable.
So probably that was what I wanted to highlight. So the supination can be corrected. Well, there's another very common problem that there's the association of the hallux valgus with the flat foot. Does it influences your algorithm for the surgery? And what is how you go ahead first, second, at the same time? Questions to both of the speakers, the Indian as well as their perspective.
Dr. Ajay, you want to go? I can talk after. Yeah.
Okay, so
I'm sorry. A lot of questions from my side because I don't have anything in the chat box.
okay. Okay, so yeah, so if there's an associated hallux valgus and this with the pes planus, I think we first address the collapsing foot itself. Try to attain the right position with regard to the hindfoot alignment itself. So we image it, we check it clinically on the table, image it, and make sure that we have got the whole thing correct. Means we got the hindfoot correct. Then try to align the hallux, means try to align the valgus to the same thing. Now, if there is an associated MTP arthritis with it, I think sometimes a fusion would make sense at the MTP joint. But then in case it's a very flexible kind of a hallux valgus, I think we can plan for an osteotomy. I'm more familiar with the triple kind of an osteotomy where even if there is an associated metatarsus which is slightly in the adductus kind of a thing, then we can do a proximal osteotomy and a distal soft tissue release and realign them. So I think that is what I would probably be doing. And at the same time, I also just wanted to check in case we want to do a TMT fusion, because I wanted to ask this question to Dr. Vinay. When we are doing a TMT fusion with the hallux valgus correction, so do we determine the position on table itself? Because do you replicate a weight bearing to see where that foot is going to stay? Because I have ended up actually fusing one of the patients and it wasn't very appropriate. So at the end, I found that the foot is not actually completely touching the floor. So just wanted to know your tips and tricks for that as well.
So a good question. I think if we are addressing here a flat foot construction which has been done and now patient has hallux valgus, and as you said, we are doing lapidus or first TMT fusion. So what I typically do, of course, apart from preparing the joint, I put in two pins or guide wires, one in the metatarsal, one in the first cuneiform. And basically, as you all know, I mean, usually you have to rotate the metatarsal as well as do like a lateral close wedge to correct that metatarsus adductus. So what I do is I put one pin in the first metatarsal, more plantar flex, because I know I have to basically get the first metatarsal rotated back to its neutral alignment, and then try to start at almost 90 degrees and get them together, and then temporarily hold it, and I put a foot plate underneath to see whether both are in good alignment. So I think one pin and then the other pin is almost 90 degrees to it in the metatarsal and rotate it, and then you basically hold the position to see. That's my kind of trick, if you will, and then you have all sorts of new devices here to get a clamp around it, and then bone graft if needed, and then you go ahead with your fusion with plates and two cross screws.
My one question was whether you state the procedures or you do it at the same time, the hallux valgus connection and four-foot reconstruction.
So, some patients depends. Some patients will say that it doesn't bother me. And I've had both patients actually, where they had a flat foot deformity, and it's almost tempting as a foot and ankle surgeon to say that, do you, and I'm sure you have in your clinic too, And so initially I used to think about it, but I don't try to fall in that trap. So I will ask my patient, do you want to get it done at the same time? And it is bothering you. So I think if some of them will, so again, I think it's patient driven to a certain extent. Some will say, you decide what you think, and that can be a hard call. But I think coming back to the answer, I do offer them if it is significant, like moderate to severe valgus, and I will tell them it may get worse and continue to get worse. So I think that's our deal. I give the patient a choice, and more often than not, they will probably, if it's a moderate to severe, they'll say, yeah, just get it done at the same time.
There's another new thing which is cropping up with time, that is minimal invasive surgery. And I would just like to know what procedures in flatfoot which you think can be done through these minimal invasive techniques. Because even Ajoy is doing, I did most, you guys must be doing. So if both of you can throw some highlight of, on the procedures you can look after, with minimal invasive surgery.
So I think minimally invasive calcaneal osteotomy is now pretty much widespread. Everybody, I think a lot of people do it. I personally do it too. And I think that's like one of the most common procedure now in regards to the flat foot that you can do with a burr, like a Shannon burr, and you do basically a calcaneal osteotomy and then put a screw. So I think that's the most common application for MI surgery for the calcaneal osteotomy. I do not have personal experience of joint fusion, although I'm trying now to do some midfoot fusion. For example, if you're doing any fusions or lapidus to do with the burrs, I don't have much experience with that, but I do have at my disposal, and I plan to do that in the future. But calcaneus, I've done it. Yeah, I think it works out very well. The sural nerve, once you protect it, and the wound healing is great. And I think it's a quick procedure as well. So that's what I would apply for now.
I have totally switched on to MIS and calcaneus osteotomies personally. What about you, Dr. Ajoy?
Yeah, I think those would be the same indications. I think we cannot extend it any beyond that, and I think that's where we could utilize it. And of course, going with the extra-chest stabilization, that of course we could call it as a minimal invasive procedure too.
So we have just 4 minutes, and something about the latest developments like PCFD classification, weight-bearing CT scan. Do you think that these are going to add to our knowledge and our thinking? What is going to happen in the future? Are we going to base our decisions on this weight-bearing CTs and all these things like new algorithm like PCFD and all? Is it going to influence our decision making?
So I think, yeah, Dr. Ajay, do you want to answer? I can follow you, sure.
Yeah, both of you, these are something new things which are happening. And I just wanted the opinion of both the speakers on this.
Okay, so
Mike, you can go ahead.
Yeah, okay, so, sorry.
Oh, no problem. So I think, so two separate issues. One is the classification, and I just remember reading a paper recently, and I think Dr. Ajay also published or rather read another third paper about another classification coming through. So the PCFD is becoming mainstream, number one. I think there was a paper about inter and intra-observer reliability of this classification. I'm talking about the PCFD, and they were not sure about it. I think they found that there was probably intra-observer reliability, so the same doctor could get the patient in the same classification, but inter-observer was not, as it was still kind of not quite there yet. So I think it's not, I don't think it's mainstream, but I think in regards to the reliability issue, I think probably more papers will come to see whether it is worthwhile, because somebody might say, no, this is flexible. Somebody might say this is not peritalar subluxation. So I think it's hard to say. It makes sense though, the classification, because it describes so many deformities, and we know one part of the foot is different than the other, where one is rigid. And coming to your CT, yes, I think weight-bearing CT is definitely going to be mainstream. It is all over the place. Every foot and ankle society meeting, there are weight-bearing CTs for bunion surgeries, for flat foot, and I think it's going to be mainstream, definitely, yeah. And even there are classifications, weight-bearing CT classifications coming up. Thank you.
Last question from the chat box, and this is last what you do for the flexible flat foot with the hyperlax increased Beighton score. What is the take on that in a young, this is from the chat box, let's say a 10 or 12 years or something like hyperlax person with a flexible, how you approach that. And this is both of the speakers, and then we can wrap the session.
Dr. Ajay, I want to go quick.
Yeah, in a hyperlax, I think we will have to consider all other things also. Just performing one or two surgical procedures in these cases might not work, because I think we'll have to, in addition to addressing the position of the joint itself, we'll also have to address the ligaments per se, and if they are causing any pain or not. I think very often these hyperlax individuals are so very flexible that they might not complain of pain at all. I think in those instances, offering a surgical procedure, I think, is not very well justified.
I concur with
It's
Dr. Ajay. I
painful
think
and
if the patient is not
surgery.
symptomatic, then obviously I wouldn't touch the patient, because your surgery is going to fail. The soft tissue procedure we mentioned, the bony and the soft tissue, the soft tissue is going to fail. The bony procedure may work to shift the, so if you're doing bony, like a heel osteotomy, it's definitely going to work, right? So I would probably do the calc osteotomy, but I think it's brave to expect the soft tissue to heal correctly. Yeah.
Well, thank you so much, speakers. We had a really good interaction and nice meeting you, Dr. Vinayak, personally. This is the first time we have interacted. And I think it's time to wrap up the session. And I hope we have delivered the message we were intended to do. On to the organizers, please. Can we go ahead with the other?
Thank you for the session. Yes, we will start the next session. Before that, we want to play a small video sent by Dr. Rajesh Simon for the Ifas invitation. Vasu, can you share it, please?
Respected teachers and my dear friends, a trailer of the movie starts before the movie is made. And today, as an IFASCon curtain raiser, we will be learning about the basics and a little bit of advancement of the foot and ankle problems. But the main big program is in IFASCon Kochi. That's going to happen from August 22nd to 24th in Kochi, Kerala. So on behalf of the organizing team of IFASCon 2024, I invite you all and learn to save the feet, and learn to save the feet from the masters of the world. Welcome to Kochi once again, and I hope to see you all there.
Thank you, Vasu. Can we go on to the next session? Siddharth, please introduce.
Yeah. Thank you, Inderjeet. So we have witnessed excellent talks, excellent deliberations and discussions. And now we move to the last leg of this curtain raiser, which is a very, very interesting discussion on total talar replacement. And it is an honor and a privilege for me to introduce our first international speaker, who is none other than a rock star of foot and ankle surgery, I would say. I welcome Dr. Celine Parekh, who is much more than a foot and ankle surgeon, guys. So he is a master of 3D printing. He has pioneered in artificial intelligence. He is a master's of business administration. And Dr. Parekh, I feel that you have much more to teach us than foot and ankle surgery. And I'm sure the audience is going to love your experience with total talar replacement. Over to you, Dr. Parekh.
Well, thanks so much, Siddhartha, and thanks everybody for watching. This all started years ago, almost 15 years ago, when I met three Indian surgeons when I was there in India, and we decided to really push foot and ankle for reconstruction in India. And it's amazing to see the growth that has happened in India for foot and ankle, and to see almost 1,000 people as members of IFASCon or IFAS. So, one of the things I like to do is think about things and words and a word for the year. And I think commitment has been a phenomenal word that would really sum up the advancement Ifas has made over the last 15 years. And the commitment to all of you guys to learn more about foot and ankle. It's been phenomenal to see these last two lectures and to hear what's going on in India. So thank you for allowing me to be part of this. So I'm going to talk about total talus replacement. And I'm going to give you the US perspective, which started about 15 years ago, well, about 10 years ago. All right, so we're going to talk about total talus replacement, and here are my conflicts. I recently moved my practice from North Carolina to Princeton, New Jersey. Most people know Princeton University, but we are right in the middle of New York City and Philadelphia. So it puts us in the hub of being able to get out to almost anywhere in the world. Now, when we think about the talus, remember, the talus is a crucial bone that's important for ankle movement and stability, and it's largely articular. And that is one of the reasons why you're going to see this technology works. It is injured, it has diseases, it can fracture, and all this can lead to joint pain, stiffness, arthritis, and mobility issues. For patients who require total talus replacements, it's usually those patients who have end-stage talus disease, an extruded talus or osteomyelitis of the talus. They may have severe talar fractures, either acutely or comminuted or malunited or non-union. They can have severe arthritis or necrosis or AVN of the talus, and that could be collapsed or its normal height. And they may have failed previous surgeries like total ankle replacements that have then gone on to lead to talar subsidence and large cysts. So when we think about opportunities to salvage the talus, we think about three different options. Total talus replacement, which is TTR, TATR, which is total ankle total talus replacement. You can do a TATR, which is a total ankle with a total talus and a fusion. And then obviously the gold standard, which was arthrodesis, which I think is going to be replaced. So total talus replacement outcomes, remember, this is a complex procedure. There are multiple sides that can be available. The success rate has been fairly high in early outcomes, and I'm going to talk about this a little bit more. Patient education is important because you need to have the patients understand what they're about to get into, but we have seen success with mobility and pain reduction with total talus replacement. Now, when we think about total talus replacement, we've got to consider age, we've got to consider patients' overall health, their bone quality, and how much bone is involved, either in the talus itself or in the surrounding bones. We know that these patients can have high risks and high complications, ranging from chronic pain, infection, advancement of arthritis around the total talus replacement, and progression that requires further surgery, and even conversion to a TTC or a below knee amputation. Now, typically, this is a very fast recovery. We get these patients as outpatient surgeries. They're in cast, not walking on it for 3 weeks. And then after 3 weeks of not walking on it, they're walking on it in a boot. And then they start physical therapy at 6 weeks. And they're out of their boot in 6 weeks. So we're going to talk about some of these cases. Here's a 19-year-old woman. One of my first cases had CML leukemia at an early age in her teenage years. Pediatric vascular necrosis of the talus developed secondary to a prednisone exposure in her early teenage years. So she has pain bilaterally. And if you look at x-rays, maybe you see a little sclerosis in the talus. But when we get the MRI, you really start seeing the amount of avascular necrosis in the talus, somewhat in the tibia, and the calcaneus as well. And you see this pretty dramatically in the talus. So your options are to do a TTC fusion, but remember, she's got it on both sides. So to give a girl, anybody, a TTC fusion on both sides can be highly devastating. So this patient had a total talus replacement. We have trials that we create, and then using a CT scan, CAD drawings, and 3D printers, we can recreate the normal anatomy, which you see on the right side. Our approach is a standard anterior approach. I like to take the EHL out of its sheath and retract that laterally. We'll do a talar osteotomy at the talar neck, take a wedge of that neck out. And by doing that, you separate the interosseous ligament from the talar body and the talar head. We then take the talar head out, the talar body out. And when you do that on the right-hand side, you'll see this big hole that you're left with. We can take our trials and drop it into the joint like you're seeing here on the left-hand side. And then we've got multiple trials. So the way you know the right trial is you'll hear a thud. And when you hear that, that's how you know you have the right trial. And the motion that you get with these implants is amazing. You can see this again. I'm going to play it again for you because it's pretty dramatic, the motion you'll see in plantar flexion, dorsiflexion, but also abduction, adduction. And you just can't see that with TTC fusions. And so this patient came to see me again 6 months after her first one and got her other one done. This is a patient of mine who had this total talus done 3 months prior to this video. You can almost not tell which side she had it on. It's her left side. And 3 months afterwards, she's doing these type of box jumps. That's not the patient, but that's the type of box jump she's doing in the gym. Against medical advice because we don't want them to do impact activities. But again, they can do a lot of things and have high mobility. So as we get comfortable with total talus replacements, you can start tackling patients who have ankle arthritis. And here's a patient with AVN with ankle arthritis, and we do a tator procedure, total ankle with a total talus. Here's a patient with ankle arthritis, talar AVN, subtalar arthritis, and we can do a tator with a subtalar fusion. Here's a patient of mine who had a cavovarus foot deformity, and when she came in to see me, she said, Dr. Parekh, either give me motion or take my foot off, BKA, but do not give me a TTC fusion. Terrified of TTC fusion and the complications and the loss of mobility. So she said, I'm giving you permission to try anything you need to on me. So we gave this a shot. We said, okay, we got to fix the deformity first. We took her to the operating room, put the external fixator on. When I did this, the talus looked questionable. So we put a cement spacer holding her alignment correctly and then did a tator with a subtalar fusion. And although she's got some subsidence, she is doing well with minimal pain. Here's a patient of mine that I had done a triple arthrodesis on, developed ankle arthritis, needed a total ankle, and then was lost to follow-up for 4 years. Now, when they come back to see you after 4 years, you know something's wrong. So take a look. I'm going to scroll between these two pictures. Pay attention to the right side. Look at where the talus is when I put it in, and now 4 years later. You can see the subsidence in the talus. This talus is subsided down. So prior to 3D printing, we did not have an opportunity to salvage this. We'd have to take all of this out and do a TTC fusion. But now with 3D printing, we can give this patient a tator, a total ankle, kept a stem with a poly, a brand new poly, a total talus, which entirely on the bottom of it has a fusion, okay? And this is the power of 3D printing. Here's a patient of mine. This is her car, 19 years old, had a motor vehicle accident and has seen in the trauma bay, open talar extrusion on the left side, on the right side, open pilon fracture. Goes to the trauma bay. The trauma surgeons offer the family a primary amputation on the left side. Mom says, no, don't do that. She gets goes back to the site of the car accident, finds the talus the next morning, brings it to the surgeon. Surgeon says, you know, can't do anything with this now. It's dirty. I can't salvage this. She needs a BKA. Mom gets on social media, finds out what we're doing, and asks the surgeons to send the patient to us. So she comes to us. This is her X-Fix. You can see she's got a partially extruded talus, but also the medial malleolus is missing. So again, normally this would be a TTC fusion, but we thought, let's see if we can help her out. Let's see if we can recreate a medial malleolus and give her a total talus. So here's our medial malleolus we're creating. These are our cutting guides to freshen up the bone that on the distal tibia that's been impacted from the medial mal fracture. We recreate the medial mal. We have it roughened at the tip of the medial mal so that the deltoid ligament can scar into that area. We have a stem going into the tibia and a plate on the medial side of the tibia, locking that stem into place. And then we plan the total talus. And this is what she looks like. She's 5 years out from surgery, has her limb, is able to wear heels, is able to date, barely has a limp. Pain is about a 1 to 2 out of 10 pain. And really, this is dramatic because if she had a TTC or an amputation, her life would be dramatically different. Here's a patient of ours who came from Hawaii, about a 6-hour plane ride away from me, had an open talar fracture, had it pinned in Hawaii, got an infection, came in to see us. We got the bone scan, lighting up, bring the patient to the operating room, clean it all out, has osteomyelitis, so we put a cement spacer, is growing out propionibacterium, so we've got to clear the infection. Now, this is the first case we did where we did a tator, total ankle, total talus with a subtalar fusion and a talar navicular fusion. So you can see all of the areas for ingrowth at the subtalar joint and the talar navicular joint. We put a lot of biologics. So we use the patient's own stem cells. We use and bone marrow aspirate. We'll use autograft allograft from the patient, allograft from obviously cadaver. And then I like to amp this up with BMP. And so I layer this over all of the fusion sites, and this is what this looks like intraoperatively. This is him out 5 years later, has actually gone on to gainful employment and is living a gainful life. Here's a patient of mine just recently has an agility total ankle, 20 years out. This lasted 20 years and now is having pain. Had a triple arthrodesis done somewhere else. The talar component subsiding, has this large bone loss on both the tibial side, but also medial and laterally. And this is a challenging case. But with 3D printing, not so challenging. So you can bring this patient to the operating room. This is a custom tibia to have a little stem that goes into the tibia with a custom total talus, with a fusion of the subtalar joint and the talar navicular joint. And he's a year and a half out. Pain is 1 out of 10. His activities are as tolerated, except for impact activities, and he's doing well. And hopefully we can get another 20 years out of this for this patient. Now, the interesting thing about 3D printing is we can start really addressing things that people don't talk about. So I'm becoming a bigger believer that there are allergies to these metals that are supposed to be inert in the body. And we are doing more and more of studies of this. And I actually have a larger and larger number of patients who have this. So here's a patient who had a total ankle done within a year, had a revision done for pain, came in to see me. So she already failed 2 total ankles. And we sent her to get a serum testing for the lymphocyte transformation. All right. And you can see what this looks like on the right-hand column. There's a control, so that's the top bar and pinging. But this patient had a nickel allergy that went unidentified. So 2 total ankles failed within 2 years. So with 3D printing, you can actually get a nickel-free implant. She got a nickel-free implant a year and a half ago, has pain that's 0 to 1 out of 10 pain. And she's asking me, well, why didn't anybody do this before? And I think you're going to start appreciating more and more that there is hypersensitivity can be to these total ankle or total joint patients. Those patients that you get that have pain for no explainable reason, their imaging looks good, their infection workup looks good. Think about allergy testing them. And we wrote about this, our first 3 cases. I have about 20 of these cases now. So I'm going to go through a video here with you guys on how we do the total talus replacement, because I think watching it is eye-opening. So it's an anterior approach. And as you get through the anterior skin, you want to get to the subcutaneous tissues. And once you do that, oftentimes you will find the superficial perineal nerve branch crossing that wound. We tend to like to mark that when we see it. And you'll see me mark it later in this video. And as we mark it, we will then retract it laterally. Then we'll then take the EHL tendon out of its sheath, which is what I'm doing here. And once we take the EHL out of its sheath, we will then put our retractors in. So up until this point, I do not use any retractors at all. So we put these sharp retractors in, put it deep to the tendon, because just like for the calcaneus, the skin is what you have to take care of here. Now here I am plantar flexing the ankle as far as I can. I'll take a saw, and on the anterior edge of the tibia, I will go ahead and do my first cut through the talar neck. After I do this, and I will make sure to be very careful not to hit the subtalar cartilage, especially if I'm doing just an isolated total talus, no fusion underneath. I don't want to hit that subtalar cartilage. So here I am doing a second osteotomy, and my goal is to meet distally the first second osteotomy to the first osteotomy. So I'm going to take out a wedge out of that talus. And once I do that, I'll take that bone out. And you'll see me do that. I usually take it with an osteotome to start freeing it up. We'll then take that bone out. And once you take that bone out, you now have separated the talar body from the talar head. And the interosseous ligament is no longer capturing that talar body down, more often than not. Now, I will then usually will spend a lot of time taking out the talar head. That comes out fairly quickly. And then carefully, you will take out the talar body. I like to cross hatch it and try to take it out in quadrants. And you're seeing that here. I use a Cobb elevator or periosteal elevator. And I really try to be careful about not damaging the cartilage in the plafond, especially again, if I'm doing an isolated total talus. If I'm doing a total ankle with this, I don't have to be as careful. So as you take these quadrants out, what you're going to notice is that the more dorsal quadrants, they come out easily. The posterior lateral, posterior medial quadrants are a little harder to take out. The posterior medial quadrant, which is what I'm working on here, you've got to be careful and you've got to carefully take this out. There's a lot of scarring that occurs in that posterior medial capsule. And so I'll put my Cobb elevator there. I'll really try to free it up. This is a special rongeur. It's called a long skinny rongeur. So it has a long nose, but it'll open up fairly well. And then you take that piece out. Here are our trials. I'll pop the trial in. I'll use what's called a nominal trial, which is the 100% size trial first. And from there, I'll decide, do I go up or down? Our trials are 10% up in volume, 10% down in volume. But again, when you get the right one, you'll hear it plunk into place. And once I like it, I'll irrigate this thing out. I'll make sure to get all fragments of bone out of this wherever it may live. There may be some bone residual in that interosseous ligament, sometimes in the posterior capsule, but you really want to be very particular about getting all this extra bone out. You do not want this sitting in the joint when you put your total talus in. So next, we'll take the trial out and then we'll put the final implants in, and you'll see that happen now. These implants come in cobalt chromium, which is the silver ones you've seen earlier in the video or in the pictures. We now make them in in titanium nitride, which is lighter and we think wears better against the cartilage. Now, the newest option coming out, which is very exciting for us, is the following. So I'm going to show you this through a case. Here's a patient who had a total talus with a total ankle done on the west coast of the US. Was offered 4 amputations because he wasn't doing well. Came in to see us. He had an infection, put him in an X-Fix, took out all the hardware, put a cement spacer into place, and then we started planning a pec total talus. We call this a Death Star because it's going to be a TTC fusion. And so we're going to put a stem in here. What you cannot see is the pec implant. That pec implant is ortholucent on X-ray, and it's packed with bone all around. He's now 6 months out from surgery, has a TTC fusion, but done well. This is a patient of mine who had a nickel allergy, titanium allergy, cobalt allergy, and a chromium allergy. She cannot get any implant made out of metal. And so she has AVN of the talus. This is the first implant of a total talus done in the world. This is what it looks like. It looks crazy because you can't even see the total talus. It's like a ghost in here. She's 4 months out from her surgery. So far, so good, doing well. So what's the data show? We wanted to look at our first 14, followed them out for 12 months. We showed that with a total talus, we can restore height and talar tilt, and we can restore motion of the non-pathologic joints. We then wanted to look at our early outcomes. So these are our first 15 that hit the 1 year mark. And you can see blue is pre-op, green is post-op. In green, you see we are improved on all AOFS parameters for these patients post-operatively. So we are improving quality of life. We then wanted to look at our TATR patients. So this is our first 67 patients. And we showed that there was an improvement in pain, range of motion, we restored anatomy, and we think that this is a viable option for patients who have avascular necrosis. And finally, I wanted to look at my patients who had an associated fusion with some type of total talus. We looked at our first 19. We have a 100% union rate in these patients so far, and we are counting this off. I mean, I have about 200 plus of these total taluses now and growing. We have patients coming from all around the world, and there are more and more publications coming out on this. It's an exciting place to be. And finally, I'm going to show you my extreme case. There's a patient I did a TTC fusion on 7 years prior to this X-ray, having more and more pain. We get a CT scan. It shows an ankle non-union and a subtalar non-union. So we went in, took the nail out, packed it all, impaction grafted this. 6 weeks later, came back in, did a total ankle with a total talus and a subtalar fusion. She doesn't have normal motion. She has about a 20-degree arc. She loves this. And she said, Dr. Parekh, why didn't you do this from the beginning? We didn't have the technology. So how are these patients doing? Pain lives at about a 1 to 2. I have a firefighter who's back on the force. I have a golfer who plays 18 holes of golf 3 times a week. I have a patient within 6 months won the senior games for a local state in the US. I showed you the patient who did box jumps. So total talus replacement is complex, but I think it's going to transform the care of patients who have avascular necrosis for whatever reason. They have improved mobility, and the material advancement that's occurring in the world is going to make this such an exciting area over the next 10 to 15 years of my career. Thanks.
Thank you, Dr. Parekh. That was an enlightening talk, and I'm sure we'll have a number of questions. But let's look at the Indian perspective now. And again, it's my privilege to invite one of the pioneers of Indian foot and ankle surgery to present the Indian perspective. This is none other than Dr. Rajiv Shah. So he's one of the most well-known and respected foot and ankle surgeons from India. He is amongst the first foot and ankle surgeons who established his own practice. He has been a pioneer and a senior member and president of many, many foot and ankle societies. Most recently, he's been the immediate past chairman of the Asia Pacific Foot and Ankle Council. So he has also done pioneering work on total talar replacement in India. And over to you, Dr. Rajiv Shah, sir, for your experience with the Indian perspective.
Thank you very much for the kind introduction. Let me share my screen. I hope my screen is visible and I am audible.
Yes, sir. Please make it full screen.
Yeah, that's okay. Is that okay?
Yes, sir.
Yeah. So let me start with a case. 39 years old male who had a road traffic accident and polytrauma, had a chest and abdominal trauma, bilateral femur shaft fracture, fracture of proximal tibia, and on the same side, he had a compound right ankle injury. He was shifted to us for the further management. And if we see his X-ray, he had this kind of open right ankle injury and the whole talus was missing. So lost talus after debridement, this was the status of anterolateral wound. And the question was, how are we going to bridge the defect? So we took in a cement spacer, antibiotic impregnated cement spacer, which was shaped like talus, and this was put in. And an external fixator was applied. This was the post-op X-ray, ipsilateral femur plus tibial condyle plus ankle fixation. This is how it looked. It was 3 days after the injury that the relatives, they came with this lost talus and they said that this is the talus we found out from the injury site. This is how it was brought, and then this is how it looked after cleaning. This was how it was looking after cleaning. So what to do? To put this talus back or to throw it? Obviously, we decided not to put this talus back. This is how the status of wound was. There was no infection. And then options were TTC fusion or something else. So we got the CT scan of extruded talus and a 3D printable file was created. A trial model with 10% reduction into the size. There were holes for the anchorage of this talus. There was a hole for extraction and impaction. This is how a metal handle was also prepared. So this is what we got. Only one processes. If I tell in the language of cricket, last ball you hit 6 or you are out of the game. So this was a medical grade titanium which was 10% less into the size. So 3 months post-trauma, we went in with an anterior approach. As Celine described, it was between the EHL and extensor digitorum longus on the lateral side, EHL on the medial side, and the spacer was removed, and this gap was then filled with this prosthesis. For our first kind of this processes, we had holes made where the fiber wire was passed, and I anchored it to the talonavicular capsule and navicular bone itself. This is how it looked on table, and that was India's first total talus replacement. When patient was mobilized at the end of 2 weeks of mobilization, this is what his movements look like: inversion, eversion, and dorsiflexion, plantarflexion. And then he gained almost normal dorsiflexion, plantarflexion with slight restriction of inversion and eversion. And this is how he is at the end of 6 years post surgery. He does traveling from my city to other city through train and through multiple other vehicular options. So this is where I am here to share my experience, Indian perspective. This is not a big experience, but let's talk about the Indian perspective of 3D printed total talus replacement. As Dr. Kadakya in his paper stated that these are the indications: failed ankle arthrodesis, failed arthroplasty, avian talus, absent talus, segmental bone loss, deformity. And he also in his paper stated relative as well as contraindications. But for us in India, our commonest indications are post-traumatic malunion of talus, non-union of talus, avascular necrosis, and deformity. These are the key indications. So the process which I follow is slightly different than what Dr. Celine follows. The first thing is that I get CT scan of minimum size, say 1 mm, 1.5 mm size CT scan of both the ankles. And I get three plastic models, 10% low in the size, 10% higher in the size. But the most important is I get the model of the affected ankle. So when I'm supplied with these three +1, -1, and 0 model of plastic model of total talus, I try to work with my ankle model and try to evaluate 0, -1, and +1 and check how is the fit of this particular model, and accordingly I ask the company guys to make the model. So that's how I get the models, and they are like +1, 0, -1. And there is a nut which I want to put in. If I want to extract it, this nut helps me because the tissue ingrowth is prevented, and the handle is a handle which with which you can extract, with which you can even impact, with which you can even push the talus inside. And again, same supine position, anterior approach. Celine showed a beautiful a video, and the osteotomy of the neck of the talus, and then three such incisions into the body by osteotomes, and then remove the complete talus out, making sure that you don't damage talonavicular or subtalar joint. This is how it looks like, and then that's how you implant inside the body, and this would be the postoperative X-ray which you see. My post-op protocol is little slurred, little overcautious. A below-knee splint for 2 weeks. Once the sutures are out, I give a below-knee plaster for 6 weeks. Patient is asked to avoid weight bearing onto this plaster for 3 weeks. 3 weeks down the line, my patient starts weight bearing with the plaster, and then 8 weeks post surgery, I start complete weight bearing mobilization. Gradually, as my number of cases has increased, I've become little more bold onto mobilizing my patients. Some cases, this was a 36-year-old female who had avascular necrosis of talus. You can see it on the x-rays. These are the CT, MRI pictures, coronal images showing the destruction. She was in pain, and then she got this kind of total talus replacement done. She was so happy at the discharge. She wrote a poem, and she wanted me to recite the poem. And this is at the end of 4 months that she has gone back to all her routine activity, and she has got normal inversion, eversion, and normal dorsiflexion and plantarflexion. Another case who had a fracture dislocation of talus. This guy, he went to one doctor, he tried, he could not reduce this. Then he went to the other doctor who said, I have reduced your talus, but talus was not reduced. He went to the third doctor, and ultimately at the end of 4 weeks that he was sent to us, we tried hard to reduce it. We could not reduce it, and then the talus was excised and an external fixator was put in. And this is how the CT looked like. See, he underwent total talus replacement. These were the plastic models with an ankle model. And here we tried some kind of innovations. We tried to create lateral as well as medial ankle ligaments with the internal with the fiber tape. This is how it looked on table. These are the titanium models. These are the plastic models which are autoclavable. You have it on table. Again, anterior approach, trial reduction, and then final implant was put in. This is how both the ligaments we tried to restore on table. This is how it looked, and this were the movements on table. Looked pretty, pretty stable. And he, at the end of 4 years, this is how he has gone back to his normal routine. Very recently, he sent me his videos and he got engaged. Case number 3, 18 months old, neglected, poorly treated talus trauma. This guy had some deformities. We had to do some additional procedure together with total talus replacement, CT scan of opposite side, 3D printed file creation, 3D models created, anterior approach, talectomy, and implantation of total talus. And this is how he underwent lengthening of the tendo Achilles, posterior capsulotomy of the ankle, posterior capsulotomy of the subtalar joint. He also underwent a calcaneal osteotomy and DIP fusion. These were the additional procedures we required to do in this case. And then he's gone back to all his routine activity. This is now at the end of 4 years post surgery that he has gone back to all his routine activities. The last case, 28 years old male who had avascular necrosis of talus. These are his MRI pictures, and that was the final X-ray after implanting total talus. And these are the movements at the end of 6 years. He has gone back to all his routine activity and is happy. So this is another longest survived case. These are multiple kind of talus replacements which we got. So if we talk about our experience, it's an unpublished series of 14 cases where 9 cases were post-traumatic and 5 were avascular necrosis. We had 2 cases where we did total talus replacement plus subtalar fusion, and we had 1 case where we did total talus replacement with talonavicular fusion. Additional procedures are needed in most of the trauma cases. The kind of trauma cases which we get 2 years old, 3 years old, they really have a lot of soft tissue contracture and you need additional procedures. The longest surviving cases are from 6 years. So 2 cases have survived for 6 years. In fact, all cases which we have done, they are surviving. They have near normal ankle range movement. They have terminal restriction of inversion and eversion. And innovations neither work or nor are necessary. So I've been trying to give some ligament reconstruction or some sutures around the tissues. But after doing this, I realized that they are never required. So, friends, good results, they come from experience. But experience comes from the bad result. So let me share my failure case. This was a patient who was treated like this. This was after 3 years that he presented to us. We offered him TTC fusion. He wanted movements. And these are his clinical picture. And we got the total talus replacement implants created for this patient. On table, I had a huge struggle to put my implant inside the ankle space. I used Hintermann distractor, I used laminar spreader, I used femoral distractor, everything failed. I did open tendo Achilles lengthening, I did posterior capsulotomy of ankle and subtalar joint, I also did plantar fasciotomy, but that did not work and I could not push talar processes inside the ankle. I had to leave him with the half reduced talus processes with support of XPIX. And then there was no other way except to come later date and remove this processes and do something else. So in retrospect, I realized that he had equinus, he had cavus, he had set arthritis of the ankle. There was no space to accommodate implant. Maybe it was a wrong case selection. Maybe I would have done 2 stage. Maybe I would have taken measurements after correction of the deformity in the 2nd stage. And then when we removed the TTR implant, our question was how to bridge defect at tibio-calcaneal fusion. And this is the technique which we use. It's called a bamboo hut technique to do tibio-calcaneal fusion. The fibular grafts are put at the 12, 3 and 6 o'clock and these grafts are sutured with each other and then they are compressed like a bamboo hut. And this was a technique published. So this is what we did for this patient. A lot of iliac crest bone graft plus fibular bone graft. To end, what would be the future with regards to total talus replacement in India? Yeah, we have seen Celine doing fantastic innovative surgeries. But then if you talk of ankle replacement, implants are not easy to procure in India. So a 3D printed patient specific total ankle replacement is what is being developed and it has been labeled as in-joint total ankle replacement. This is with the 1 mm CT scan, you plan, design, and then you take the femoral and talar cut. These are the patient-specific guides being produced for that particular patient. And this is patient-specific total ankle replacement implant design. These are the instruments which are patient-specific. And this is how you put in tibio and talar component. These are the x-rays taken into the cadaver. This is labeled as in-joint 3D printed total ankle replacement specific for this patient and it is in line for patent registration. And the future would be in-joint 3D printed total ankle replacement plus a total talus replacement under it. To sum up, early results of total talus replacements are good and encouraging, but long-term studies and strong evidence are the need of the day. Availability and cost of implants are constraints. That's all. Thank you very much for your patient listening.
Thank you, Dr. Rajiv Shah, sir. So let's kick off the discussion with something which everybody would want to know. And this question is to both speakers. So what is the cost of a standard total talar replacement in the US, Dr. Parekh, versus India, Dr. Rajiv Shah?
Well, I think obviously it's hard to compare price from one country to another. So I will compare it to a total ankle replacement. A total talus replacement is slightly more than a total ankle replacement. And then in the US, depending, our healthcare system is very complicated. But basically, the bottom line is it can range anywhere from $5,000 to $12,000 US, depending on a lot of different factors.
So very recently I introduced saline to the vendor through which I get the total and talus replacement. It's quite cheap than what they get in US. In India, we get 3 implants at the cost of 1.5 lakh rupees. So it's like how much in the USD? Is that 1400,
Around
1600 USD?
$1,300, yeah.
So that is what it is.
Okay. So
It's
it's
about
just
4 weeks for us to get it. I do not know how much time do you people need saline there in
yes, that
US to
was
get
the
it.
next follow-up question. So what's the turnaround time for these printed prostheses?
The US, they can make it within 4 to 6 weeks, but that's not from the time I see the patient, right? Because we have to see the patient. If they don't have a CT scan, we have to order it. Then in the US, we have to get this approved by the insurance first. Then we send it to the company to be made. So when you add all those timelines, it's about 2 to 3 months.
Great. So the
For
next,
for India, it
yes.
is Siddharth. For India, it is like you get a CT scan, you send the 3D printable file, and then vendor prepares a 3D plastic models which you match, and then you decide. Sometimes you're gone for -1, -2, and 0. Sometimes it is 0, 1, 1 plus something like that. And that takes about 10 to 15 days, and then printing and getting it in our hand would take another 3 to 4 weeks. So in all, 6 weeks max.
So Dr. Rajiv Shah, when you say match, do you actually take those models and do an X-ray on the patient to see if it is sizing well, or you do all of this intraoperatively?
No, I get a 3D printed model of that particular ankle where you're going to put this in. Because what I've seen that we have got more of trauma cases where the contractures are more. So in that 3D printed model of the ankle, I would put in, as I showed in one of my slides where the videos where I'll put in the implant and I'll physically check whether it is fixing well or it is loose or it is very tight. And this gives me an idea that what size I actually want. And then accordingly the sizes are prepared. Then obviously on table.
So, Dr. Parekh, is this a fundamentally different approach? Because from what I gather from Dr. Rajiv Shah's approach is they take the talus of the normal side, create a mirror image, and then size it up and down. Do you do the same thing, or do you have a shape model or something which you would just up and down?
So same exact thing. However, if you have AVN on the affected limb and there is no collapse, then we just use the affected limb. We'll always get the contralateral limb for comparison, and we'll volume match to see how close we are to being a normal height talus. But we do the exact same thing. We always want to look at the unaffected side.
Great. So the other question, Dr. Rajiv Shah, you touched briefly upon it and is to both speakers. So what do you do with the ligaments? I know that you discussed it somewhat at length, but it is interesting to know what do you do with the ATFL or with the deltoid ligament? And more importantly, how do you preserve the deltoid ligament when you're dissecting out that talus?
So I get this question all the time, and you can do exactly what Rajiv's doing, and some people in the US are doing the same thing, creating these 3D printed models or 3D taluses with ingrowth surfaces with holes for some kind of suture tape type device. But the vast majority of them don't need any of it, right? So what I have found is that if you are very careful about subperiosteal elevation of the soft tissues, the vast majority of that ligament is in those tissues, right? And if you're careful about preserving the posterior capsule, then when you close this ankle up and when you have them immobilized for 3 or 6 weeks, that capsule, soft tissues, they scar in, they tighten up, and we have not had, I've only had one out of I've done close to 200 of these, only one that later on ended up with a cabovarus issue because the talus started collapsing, and she had underlying neuropathic issues. So I don't know if it was all due to the soft tissues or her underlying issue, but I think I personally have not felt that there's a need to do the reconstructions as of yet.
Well, I feel that when you are treating a trauma which is subacute, then and you're doing the reconstruction, I feel that the need to do ligament reconstruction is deemed. And that's what I did in one of my cases where a sister of an orthopedic surgeon, she had a fracture dislocation talus, tried at three places to reduce, and then they came to me after a few weeks, and then I also tried to reduce under anesthesia. I did everything, I could not reduce, and then I just put in xfix, and then it was like decided this comminuted fracture dislocation should we be going ahead at the end of 5 to 6 weeks to re-reduce it, open reduce it, or we should be doing total talus replacement. And then they opted for total talus replacement. And there I did reconstruct the deltoid ligament as well as lateral ligament with an fiber tape, with an a knotless anchor pushed into the talus implant and a knotless anchor which was sutured to the deltoid ligament, through which it was sutured to the deltoid ligament as well as lateral ligament. And he's doing pretty good, though I slightly over tightened the deltoid ligament, and so there is slight varus, but he's doing well. It's now 4 years, but doing well. So acute cases which are very closer, I mean, we deal with trauma more than the AVN here in India. So I feel such cases do need ligament reconstruction.
Well, and to
Having
your point,
spoken,
Rajiv, to the implants that you've designed, having those holes, there's no downside to it, right? I mean, they're always there. So if you need it, you have it. If you don't need it, it doesn't matter.
Great. So the next technical thing, and to both of you, Dr. Parekh and Dr. Shah, is you talked about sizing of the implants. Dr. Parekh, you talked about that clunk when you put that talus in,
Yeah.
but should you also be looking at X-rays and if fluoroscopic images, if I may, and do you look at those, and then what parameters on X-rays do you use other than the clunk, or is that the only thing that you use?
I really rely on the clunk. It's almost like the bipolar, right? When you used to do hip fractures, I don't know if you still do them, that bipolar, and you want to hear it like really suction in. It's the same thing. I have taken care of patients who've had total taluses, tali done elsewhere, and I think they were oversized. And those patients, many of those patients have developed arthritis in adjacent joints, and I personally think they were overstuffed. And so these patients start eroding quicker against the implants.
well, it's equally important to look at the radiological image. That's what I feel, because sometimes you get the sound and you might have fractured something. So I always start with a size lower and look at the tissue balancing, clinical tissue balancing, and how lax ankle is. I move the ankle, and then I also do it under image where I take the pictures, and under image also I like to move my ankle and see. And then I'll go to one size up, and obviously going one size over and above zero, I would be very, very much watchful, because earlier cases where I feel that I have slightly oversized it, I'm just waiting how many years it lasts. But I think later on, I have just become little wiser to go with one size less than a one size higher.
So that was the follow-up question, really. If, as a beginner, you had to err on the size, would you oversize or undersize it?
Undersize.
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 Yeah. Okay, so we have a question in the chat box, and this we discussed some of the aspects, but they say that how soon after an acute talus fracture, so suppose you had a talar body fracture which was unreconstructible, it was completely shattered. Number one, would you do a total talar replacement in that case? And number two, if you would, what's your time frame for that?
Rajiv?
Okay. So I would not go in before I find a reasonable tissue envelope healing. So not before 6 weeks. If at all the situation is like it has been unreducible, you need soft tissues to really balance. And that's why if you see my protocol, because I have a lot of trauma cases where I do it, I immobilize them more. And I want this fibrosis to develop, which gives me little satisfaction that implant should not walk out, or uh, that's how I look at it. And if I go early, I would definitely think in terms of reconstructing the ligaments.
I agree with that. I think that you have to have the soft tissue settle down in an acute trauma. And given the timelines I gave you for what we see here, 2 to 3 months, maybe even 4 months to get the implant, the soft tissues have settled down by then anyway. I can't get an implant faster than that anyway. So it kind of, the situation itself takes care of the issue.
Okay, so Trupti says that we have a question. Of course, Trupti, please type your question in the chat box and I will ask to the speakers. Or you can unmute yourself and go ahead and ask the speakers themselves. I also invite other speakers on the call, Dr. Vora, maybe Dr. Ajoy, if you're still there. If anybody wanted to ask any questions to the speakers, please unmute yourself, switch on your camera and shoot.
Rajiv,
So
sir,
my
Salim,
question to Celine, sorry, Kashyap. My question to Celine, is there a trick for doing perfect reduction? So is there a trick to doing reduction? Because I had an opportunity where one of my fellow was operating many miles away and I was present online, and he was operating onto total talus and he had difficulty in reducing it. So any tips and tricks to that?
Yeah, so here in the US, we do a lot of regional anesthesia, and we may do sedation or an LMA. If I struggle to get the implant in, and I even have gone down in size and I still struggle, then what I will do is I will have the anesthesiologist paralyze the patient. The paralysis gives me that extra few millimeters I need to drop the implant in. We will plantar flex and distract, but you did the same techniques that we would do if we still couldn't get it in, which was get an external fixator on it, maybe put a Hinderman distractor, anything to really try to get that extra length out.
Can I ask a question to Dr. Rajiv? When there is a trauma, you're using a spacer and putting X-rays. So do you immediately remove the X-rays and do the replacement, or you wait the pin tracks to heal for how long, and then you go ahead with the total Talus replacement?
So if I am putting a external fixator and going ahead for the total talus replacement, I don't do it immediately. So I really stage it. The case which I showed, my first case, I removed the external fixator and I did it after 4 to 5 days.
So it's normal 4-5 days. And when you are removing the fixator, are you leaving your cement, spacer in? You just remove the fixator and leave your spacer in, and then the spacer is removed at the time of the program. That's what I get.
Absolutely.
That's right?
Absolutely. Absolutely.
Thank you. Thank you.
And Dr. Kashyap.
Dr. Kashyap, you had some questions.
Yes. I don't have any experience with this procedure, but some common sense question which came in my mind is, what about the cartilage thickness when the CT scan and the prototype which we make? Doesn't it become already one size smaller? That is a one. And is there any place for a ceramic in this? Two questions.
Yeah, so at least the way we do it, the cartilage thickness is taken into account, right? So when you look at the talus, they will size it to incorporate the cartilage size as well, right? That's what we call nominal, or what Raju's calling probably 0, and then 10% volume down, 10% up is how we do it. Ceramics have been looked at in Japan, and they're doing okay. But remember, the ceramic's a little more brittle. We're worried about durability. So one of the newest things that are happening in the US is, instead of ceramics, which have not been approved in the US, for total talus is PEC, not peak, PEC. PEC is extremely light. It has the same bone density as bone, and we think it's going to wear better than any of these other metal implants. We don't know yet. Like I showed you, we just did the first one a few weeks ago, but more are coming. And so we'll have to track this out and see.
The personal discussion with the Japanese orthopedic surgeons who are also doing total talus replacement over the total ankle replacement. And then so what he said that when they use ceramic is heavier, and there was a problem that patients do have some kind of plantar heel pain. And two of my patients, they did complain about plantar heel pain because the titanium process which we make is heavier than the talus. And so is the case with ceramic.
Thank you. Can I ask one more?
Sure.
Yeah,
Yeah, please.
I've seen in my practice when I operated a lot of proximal tibias. So few patients of those cases had a adjacent fracture of femoral condyle very easily because of the stiffness which is created in proximal tibia. The same, if there is a talus which is probably harder than a bone, is there are incidents of having a calcaneal fracture easily or a pilon kind of fractures?
At least in the US, we have not seen that. I have not had a patient yet that's had a traumatic accident after a total talus, not yet. It'll happen at some point. But in general, like I have a few that have had heel pain, like Rajiv's saying, but by and large, most haven't. And so I have not seen that problem with adjacent bone fracturing. Rajiv?
No, not so far. But yes, plantar heel pain is a problem.
Thank you, sir.
So are there any more questions? Because we are almost at the end of the session. It's 12 p.m. All right. Thank you, speakers, for your presentations and for the discussion. And I don't see Indrajit online. Dr. Rajiv Shah, sir, or Dr.
Yeah.
Ajoy, sir, could you have the closing remarks, please?
So this was a fantastic curtain raiser to IFASCON, and we have huge number of orthopods who are there with us online. My sincere request and plea to them that if you want these concepts and complete concepts of foot and ankle clarified, please join us at IFASCON at Kochi in the month of August. We have galaxy of the speakers, and majority of the foot and ankle trauma and cold topics which would be of interest to general orthopedic surgeons would be discussed in this meeting. Till that time, thank you very much, international speakers. Thank you very much, Celine, to get involved into, and your Parag Family Foundation has been doing fantastic work. You could get this panel of doctors, experts, and I know that at 1:30 a.m. in the morning also you are up and above. That's great and quite appreciable. Thank you very much, Indian speakers and moderators, for this excellent, uh, excellent food, academic food. And last but not the least, I must thank Corona Remedies for getting with along with IFAS to do this program. And next year also, they are very keen to go ahead and do such two curtain raisers before IFASCON. Mr. Vasu, if you want to put in last remarks, over to you.
Yes, sir. So thank you so much, Rajiv sir and Raja sir, for giving us this opportunity to host this session and organize this session across the India. Initially, we had a lot of means like a dilemmas that how we can able to execute this program, taking alignment with the societies and all these things. But the topics which you have chosen, the faculty which you have chosen, has really made a tremendous appreciation across the medical colleges and across the orthopedic fraternity. And on behalf of Corona Remedies, we take this opportunity to execute this kind of collaborative events in the years to come. And no doubt, this is just the beginning of our association, sir. And we look forward to have many such academic events in collaboration with the Indian Foot and Ankle Society. Whenever I had discussion with an Indian foot and ankle surgeons, so there's a very few number of doctors. So no doubt, with our collaboration and association, we can able to churn out an interest in Indian orthopedicians towards the foot and ankle as their future orientation. And with the help of Parek sir and lot of international faculty and Indian faculty together, let's together nurture the skill and interest both in the Indian orthopedicians, and which will help many patients to have their life more better, their movement will be more better, and they continue to live life better with the support and experience and expert of all the experienced doctor. And no doubt we'll continue our association. And as I said with Rajiv sir, we are more keen to have Indian Foot and Ankle Society collaboration ke through masterclass program for the Indian orthopedicians, so that will be a year-long association that continue to nurture the interest of Indian doctors. Let's chunk out more plans with the support of us, IFAS, sir.
Oh, well said. Thank you so
Thank
much.
you. Thank you, everybody. Thank you very much. Have a nice day. Thank you.
Bye. Thanks, everybody.
Thank you so much, sir. Thank you.
Thank you, sir. Thank you so much.